Good afternoon, everybody. So now it's already 2 p.m. Is there any member from organizers here? Can we start, or should we wait for some more participants?
Sir, this is Dr. Avinash, sir. We will start the presentation, sir.
Okay. Thank you, Dr. Avinash. Dr. Avinash, am I audible?
Yes, sir. You are audible, sir.
Okay. Thank you so much. So I take this opportunity to welcome you all for this wonderful workshop of pediatric cardiac critical care. This is a basic workshop, but then it has, I'm very sure that all of you, when you attend this, will carry home with great deal of knowledge, which will be very important in terms of the beneficial role that it's going to play in your routine practices. So the topic given to me is fetal circulation and neonatal transition. Since the time we have started our MBBS, from the first year onwards, we have been trying to, get a hold of this topic. It is a little volatile, but then.
Okay. Hi, everyone. It's Dr. Parag and Dr. Avinash from KIMS. KIMS Cuddles, Kondapur. So this is workshop. Basically, pediatric cardiology. When we talk about pediatric cardiology and pediatric cardiac critical care, we feel that cardiac critical care means like big things. Too much major things like complicated surgery. Nothing actually. Most of the pediatric cardiologists start in emergency or probably in the delivery room, where you see some cyanotic child or you see a child where the saturations are less. So it doesn't mean that every child needs surgery or every child needs to go through a lot of major issues. So complicated, non-complicated issues are also there. So this workshop is to make you kind of realize that pediatric cardiac or cardiac intensive care doesn't mean it's a specialized care or a big things or major things. So this is to tune a basic understanding about the physiology from the birth, how we can approach a cyanotic child, how we can actually come to some kind of a conclusion, different lesions, how to evaluate them. And ultimately tomorrow when we have a workstation, we'll see a basic understanding of echo, so that at the bedside also you can do a little bit of echo and try to identify, and then how to interpret a different kind of an ECG, what are the different machines and in and around, how to choose your inotropes. And a very interesting thing is tomorrow you're going to have a workstation where actual specimens of a heart to understand how heart looks like, where is an ASD, where is an VSD, okay, how it's transcribed, how you can see that. So it's really an interesting things. So hope you enjoy this. It's really crafted well. There are a lot of topics involved today, and tomorrow we'll have a workstations. So best of luck all of you, and we have a very good speakers in around. So one of the first speaker is Dr. Babu. Dr. Babu is a neonatologist who's trained in PGI, and currently he's heading neonatal intensive care and KIMS Cuddles at Secunderabad, and he's going to talk about a very important transition which actually starts the cardiology, pediatric cardiologist starts from there. So over to Dr. Babu.
Okay. So the fetal circulation, as I was saying, has been a part of our learning since our first MBBS. So it is a very interesting thing, and parallelly it is also volatile. At times we tend to forget things because of nitty-gritty, and sometimes we tend to not to come across it more. But fair understanding of fetal circulation and understanding of neonatal transition gives a great idea, great insight into things that do happen, and it also helps in correcting situations in the fetal life as well as in the neonatal life. Which is why it is extremely important to understand the fetal circulation and also to understand the transition. Now, fetal's cardiovascular system has been designed for basically two purposes. The first purpose that it serves is to understand and fulfill the prenatal needs, which is fetal needs. Second service that it offers is it is able to modify itself at the time of birth so that the transition becomes more easy and more smoother. So the designer has made it in such a way that the fetal requirements are completely fulfilled, and at the same time the design can modify itself during the time of delivery. Now, in neonates, or in terms of even in fetus, during the process of transition, the cardiovascular system and respiration both go hand in hand. If you see ACLS, which is Adult Cardiovascular Life Support System, you understand the sequence of events, sequence of algorithm is CAB. Circulation comes first, airway comes next, and then the breathing. And in PALS, at least since time we have been reading, it is ABC, airway, breathing, and circulation. Maybe coming times it is also going to change to CAB, who knows. But in neonates, it will continue to remain TABC, temperature first, airway next breathing, and next session. So why I'm saying this is, so if we have to improve the circulation, we first have to improve the airway and breathing management. Likewise, paradoxically, if you have to understand, when we give good resuscitation to a child, a baby, the first thing to improve is heart rate, not the respiration. So the mnemonic is HRTC, which is heart rate first, then respiration, then temperature, and last thing is color. So good respiration in newborn infant is dependent upon normal circulatory changes at birth. So it is very important to understand that respiration and circulation go hand in hand. Now, there are three important structures which are very important as far as transition of circulation is concerned. So we have learned about these three structures, but it is very important to make a point that ductus venosus, ductus arteriosus, and foramen ovale are very important as far as maintenance of this fetal circulation and transition is concerned. Now, just fair understanding about what we are learning. Blood reaches and leaves from the fetus through the umbilical cord. The umbilical cord contains 2 arteries and 1 vein. Unlike we have a fair understanding that arteries are always pink because they carry oxygenated blood, veins are always blue because they carry deoxygenated blood. It is reverse. Here, in the fetal life, the arteries are blue and veins are pink. So this, if you go to if I have to have an understanding of placenta contains, it is a sum of its functions. It makes sum of functions of both lung as well as liver. So with respect to the placenta does functions of both lung as well as liver. So it has a whole lot of secretory functions, whole lot of synthetic functions. It helps in diffusion of the glucose, amino acids, oxygen, and whole lot of vitamins. So there are, if you see through the structure of placenta, microscopic placenta, there are capillaries and sinusoids. The blood from the capillaries goes and percolates through the chorionic villus, and then there is a whole lot of these microscopic processes that do happen. So as I was saying, the umbilical arteries are blue in color and umbilical vein is pink in color. So 2 umbilical arteries draining deoxygenated blood into the placenta, and they carry oxygenated blood back into the circulation. Now, this is a picture depicting what I'm saying, wherein the highly oxygenated blood from the placenta, if you can see the arrow mark, from the placenta, oxygenated blood goes into the umbilical vein, and almost around 50% of the blood reaches the IVC, which is inferior vena cava, through ductus venosus. So from there, the blood goes from IVC to the right atrium, right ventricle, and whole lot of changes do happen there. Let us understand one by one. So when I said half of the blood reaches IVC through the ductus venosus, remaining part of the blood goes into the liver, and from liver via hepatic vein, it goes to the IVC. So this is the same, repeat the same thing, wherein half of the blood which goes to the liver through the liver sinusoids into the IVC, remaining half has all gone through the ductus venosus, portal vein, ductus venosus into the IVC. So now what actually happens in the right atrium is that the blood, whole lot of blood, oxygenated blood is coming into the right atrium, and some amount of blood is also coming from the superior vena cava. The volume of the blood is more in the right atrium, and there is a foramen called as foramen oval, and it is a kind of flap-like structure wherein blood can move from right atrium to the left atrium, but it cannot move from left atrium to the right atrium because of the flap-like structure that it has. This flap actually makes it sure that blood can go into the only one way direction. Then the left, once blood goes into the atrium, it goes to the ventricle, then the ascending aorta, and then subsequently all over the body. Now, if you have to just, this picture depicts the same thing, wherein the blood is coming from the inferior vena cava, superior vena cava, and whole lot of the blood which has come from the body then goes into the left atrium via this valve of oval foramen, which is called valve of foramen oval again. So this is a flap-like structure. It can allow only movement happening in one direction. Now, coming back to the same thing, same picture, the small amount of highly oxygenated blood which is coming from the right atrium mixes with little amount of blood which is coming from SVC in the right ventricle. Then the blood from the pulmonary artery goes in through the ductus into the aorta and then into the fetal circulation. As you can see in the picture here, so the arrow mark shows the ductus arteriosus. So because of the various factors, like I said till now, some of which, the pressures in the pulmonary vasculature is very high. Pressure in the systemic vasculature is low. Again, if I have to repeat pressure, this is going to be one of very important carry-home message that we need to have. In the fetal life, pressures in the right side are high, far high as compared to the pressure in the left side. The systemic pressures are far low, which is how the blood from the pulmonary vasculature through the pulmonary artery goes into the descending aorta at the level of ductus arteriosus. And then blood goes through the whole of the body, the descending placenta, and then arteries, internal iliac arteries, through the umbilical arteries into the placenta. Now, the duct is extremely sensitive tissue. Like any other tissue of the heart, or the cardiovascular system, it is extremely sensitive to fluctuations in the partial pressures of oxygen. What really happens is when the pressures are more than 50 millimeters of mercury, oxygen pressures, partial pressures, then there is a tendency of this duct to constrict. The smooth cells tend to constrict, and which is how in the fetal life, when the partial pressure of oxygen are very low, partial pressure of oxygen in fetal life ranges between 30 to 45 and sufficient for the baby to survive. And when this is happening, the duct remains patent. After the delivery, when the partial pressure of oxygen keeps on increasing, as a reciprocative response, the duct keeps on closing. So there are other factors which also help in constricting the duct at the right time. Now, there are certain changes that do happen after birth. One change is the closure of the foramen oval. Second change is constriction of the ductus arteriosus. So, as I was saying, the foramen oval, it is a physiological structure. The physiological closure that happens because the pressures keep on increasing on the left side and flap gets closed initial few days. Subsequently, physiological closure becomes an adaptive closure because of the fibrosis of that area. With respect to the ductus arteriosus, normally in all term babies, it has been seen that almost 20-25%, 30% of the children or babies, they tend to have closure of ductus arteriosus in the first 24 hours. Slowly over next 48 hours, most of the ductus gets closed and it is functioning normally. By almost 3 to 4 days, almost 100% of the duct is getting closed. If it is not getting closed, then we might have to intervene because it affects normal functioning of the circulatory system. Likewise, there is also closure of the ductus venosus, which happens. Now, if we have to understand things that happen in the whole of circulation during the process of delivery, after the delivery, or the peripartum period, if you say, there is sudden fall in the blood pressure in the inferior vena cava and subsequently in the right atrium. This is due to the fact that umbilical cord has been clamped. There is minimal amount of venous return that is happening in the IVC. So ductus venosus slowly gets constricted. Parallelly, during the time of delivery, it is also, there is aeration of the lungs that is happening because baby tries to breathe. So with aeration of the lungs, there is marked increase in the pulmonary blood flow. This is due to the fact that the pulmonary vasculature have fall in their pressures, and parallelly it is also, there is also thinning of the wall of the arteries, which causes the thinning of the wall of the pulmonary arteries also causes the dilatation of the dimension of lumen, which helps in decreasing the pulmonary pressures. So there is decrease in increase in systemic pressures, decrease in pulmonary pressures. So during delivery, furthermore, we also know that uterine contraction squeeze the body and head, so thereby expelling certain amount of fluid from the lung and stimulating the lung to breathe, and so that there is good expansion of the lung that is happening. And consequently, there is also contraction in the uterus, thereby delivering the placenta and separation of the placenta between fetus and the maternal blood supply. And placental capillary is also crushed, and fetal systemic circuit resistance goes up almost by 2 folds. So when there is contraction of placenta, contraction of uterus, placenta gets expelled, and the umbilical vessels are clamped. So sudden rise in systemic vascular resistance occurs. It is almost to the tune of 2-fold. It might go up to 3-fold or 4-fold. So what we observed till now is fetal life, the right side pressures, the pulmonary pressures and IVC pressures are high as compared to the left side, which is the systemic pressures. Post-delivery, pulmonary vasculature pressure falls down and systemic pressures keep on increasing. And during transition, it has also been noted that because of the resistance, keeps on increasing, even if the same cardiac output is maintained, the right atrial pressure, the right side pressures keep on decreasing, and left side pressures keep on increasing because of various principles. So which we'll try to understand. So increase in resistance also briefly decreases movement of the blood into the IVC. So assuming cardiac output remains same, doubling of resistance should also double the pressure in fetal section by the formula of pressure is equal to the constant Q and the resistance. So there's a fetal circulation during the transition, as I was mentioning about flap of the foramen oval. Now on the left to right shunt cannot occur because of the fact that left side pressures are more and flap is closing, right side pressures are less, and flap is not allowing the blood flow at the level of atriums. So as a result, right ventricular output can only enter into the pulmonary artery. Initially what was happening was right atrium was pushing blood into right atrium, right ventricle as well as right atrium. Now blood from the right atrium directly goes to the right ventricle, and blood from the right ventricle directly goes to the pulmonary artery. This is during the process of transition, as I was mentioning. And furthermore, during the process of birth, transiently partial pressure of oxygen goes down and partial pressure of carbon dioxide goes up for a couple of time moments, and this is sensed by receptors, and there is initiation of first breath that occurs, and there are also some amount of gas that do occur, and thereby initiating breathing. So there is a need of at least 80 millimeters of water pressure to establish alveolar liquid air interface upon the first breath. And this is possible only when there is certain amount of increase or decrease in intrathoracic pressure. So intrathoracic pressure can be decreased by contraction of diaphragm and contraction of external intercostal muscles. So as I was mentioning, the circulatory system goes parallel with respiratory system during the process of transition. So when the baby is in the process of hypoxemia and a little bit of hypercarbia during the process of delivery, there is a stimulation that is given to the chemoreceptors, and the baby starts breathing. During the process of breathing, as the baby decreases intrathoracic pressure by contraction of diaphragm and contraction of external intercostal muscles, there is fall in intrathoracic pressure. It also helps in dilatation of pulmonary vasculature and helps in venous return as well. That is a first venous return. So pressure in the lungs goes down, so much so that there is less pressure surrounding the pulmonary vasculature as well, and there is greater difference of pressures between right ventricle and pulmonary vessels. This difference now allows the blood flow through the vessels since they are now more dilated. The right ventricle, whenever it contracts, blood goes directly into the pulmonary part, where I was saying that the pressures from the left side keeps on increasing and the right side pressure keeps on falling. So as the breathing continues, greater percentage of blood from the right ventricle enters into pulmonary vasculature, and this increases flow from left atrium, which causes increase in the left atrial pressure, which was not the fact before. Since the blood flow through the lung increases after birth, so does the return of blood to the left atrium and by extension to the left ventricle as well as. So when the more blood comes to the left ventricle, Starling forces come into action, and this increases the left ventricular contractility, increasing the aortic systolic pressure, and this thereby further increase the blood pressure, systemic blood pressure, and causing more right-left shunting at the level of ductus arteriosus. And ductus arteriosus, because of the response to high oxygen, now lungs are into action. Because of high oxygen, the ductus arteriosus starts to constrict. Pulmonary circulation improves after birth, and PO2 increases as well as thus ductus arteriosus constricts. So just to wind up, last couple of slides. During fetal circulation, right ventricular pressure is higher than the left ventricular pressure. After birth, this all reverses such that left ventricular pressure becomes greater than right ventricular pressure. Switch from thick right ventricular wall during fetal life to a thick left ventricular wall during adult life does happen over a period of time, and all those structures which you are mentioning become either rudiment or non-functional as they were before. The umbilical vein becomes ligamentum teres, umbilical artery becomes medial umbilical ligaments, ductus venosus becomes ligamentum venosus. Likewise, arteriosus becomes ligamentum arteriosus, and fossa ovalis from foramen ovale. These are the same thing. So fetal circulation, just to summarize, is a low pressure system. There is right to left shunting which is happening. Lungs are non-functional because lungs are not in the process of oxygen exchange mechanism, and there is increased pulmonary resistance, and there is decreased systemic resistance that is seen. But in infancy, in the neonatal time period, everything is opposite. The pressure, the systemic circulation, circulation, left to right blood flow occurs. Lungs become more functional, decreased pulmonary resistance occurs, and there is increased systemic vascular resistance. And this is the sum of the same thing that I mentioned before. So thank you very much for your patient hearing, and I'm open for questions, and extremely sorry for technical glitches that happened. Queries that we have. Dr. Avinash and Dr. Parag can help me out.
So any questions regarding the topic, you can put in the chat box or you can ask now. So if no questions, we'll go with the next presentation. So till now we had seen the logical sequence of fetal transition and circulation. So in the next presentation, we shall see about approach to cyanosis in neonate. So this presentation will be done by Dr. Aparna ma'am. So Madam is a clinical director and head of the department of neonatology in KIMS Cuddles, Kondapur. So over to Madam.
So with that introduction, I would like to now move on with the second session today, which is going to be on an approach to a newborn baby with cyanosis. This is one of the common clinical conditions that we deal with. And I'm Dr. Aparna. I'm Chief Neonatologist at KIMS Cuddles, Kondapur. So we'll try to keep this presentation very simple. We'll just be discussing the basic approach to cyanosis. So cyanosis, as we all know, is a very non-specific sign that may represent multiple things. It could represent cardiac as well as some non-cardiac or sometimes even hematological conditions. So without going into too much detail, cyanosis, which is derived from the Greek word cyanos, means dark blue color. And typically we appreciate this when the concentration of reduced hemoglobin in the body goes to more than 3 grams per deciliter in the arterial blood. So we all know that for someone to be able to clinically appreciate cyanosis based on the clinical acumen of the clinician, the saturations may lie anything between 85%, and for a very fresh pediatric resident, saturations may need to drop to something below 75% in order to appreciate cyanosis clinically. And a baby who is having polycythemia with increased hemoglobin levels may appear clinically cyanosed at a much relatively higher saturations because the absolute concentration of relative hemoglobin, reduced hemoglobin might be higher. Now, based on the distribution of cyanosis, this can be classified as acrocyanosis. I hope you're all able to appreciate the written content as well, the handwritten content. Dr. Avinash, is it getting shared, whatever I'm writing with the pen?
Yes, ma'am.
Okay, thank you. So acrocyanosis, as you all know, is cyanosis involving the peripheries of the body, and this can be very normally seen in a normal newborn during transition. Whereas central cyanosis, as you can appreciate in this baby, represents bluish discolorization of the palate, the oral mucosa, and the facial skin of the baby, or the skin over the central chest and trunk. And this is a more serious condition and typically is seen with severe pulmonary parenchymal or cardiac problems. Sometimes, rarely, we may appreciate differential cyanosis, wherein there could be selective cyanosis of the lower limb. As you can see in this picture, the upper limb appears normal. So this can happen with right to left shunts across the PDA. So now that we have understood what cyanosis is, let us try to see what, as a postgraduate or as a practicing doctor, we need to remember in order to differentiate the two important DDs for cyanosis. So whether this is cardiac or whether this is non-cardiac, which is commonly due to pulmonary parenchymal problems. So how can we make this differentiation based on clinical grounds and based on various investigations? Now for this, I'll go through a quick case scenario. So you're dealing with a 38 plus 5 weeks. So this is an early term, 3,200 grams neonate who cried immediately after birth. Apgars were 7 and 8 at 1 and 5 minutes of life, and the baby did not need any resuscitation. This baby develops respiratory distress immediately after birth and has a Silverman score of 5 to 6 by 10. So as you all know, a clinical score of anything more than 3 may be taken as the presence of moderate respiratory distress. This baby had severe retractions and required delivery room intubation. And on examination, the baby has cyanosis. Heart rate appears to be normal, pulses are well felt, and there is no murmur. Room air saturations were low. The baby is begun on 100% saturation after ventilation, on which saturations are still 80%. So there doesn't seem to be improvement with provision of supplemental oxygen. So this is a very important clinical pointer for a possible cardiac etiology for cyanosis. Moving on, the baby's clinical examination, as we discussed, showed tachypnea, severe retractions with Silverman score of 3. Chest is clear, There are no crepitations. Abdomen is soft, no organomegaly. The baby is being ventilated with relatively high pressures, significant respiratory support with PIP of 24, PEEP of 6, and FiO2 is 100%, and hence we decide to oscillate the baby, and this is how the X-ray looks. So what does this X-ray show? Does anyone want to type the answer? Any quick answers? So I hope you all can appreciate that both the lungs are hazy bilaterally. You can hardly appreciate the cardiopulmonary differentiation. In other words, you could say that this is white-out lungs. And there are few conditions in a newborn baby where we see white-out lungs. What are they? In a preterm baby, you would think of RDS or hyaline membrane disease. This is a term baby, although term RDS is also something that we encounter occasionally. There are some more ominous differential diagnoses, including early onset sepsis, pulmonary hemorrhage, or pulmonary venous hypertension, of which one of the important DDs is obstructed TAPVC. So this baby's blood gas was done. It showed pH of 7.258, which is indicative of acidosis. The carbon dioxide level is 44, which is just on the higher limit of normal. PaO2 is very, very low. So the normal PO2, you know, is 60 to 80 millimeters of mercury for a term baby. A preterm baby, you may accept 50 to 70 as normal. So this baby is having hypoxemia with metabolic acidosis. And echo was done, which showed obstructed TAPVC. So in this baby, we had some important clinical markers that this cyanosis was possibly cardiac. So few of them were the fact that the baby had no improvement with oxygen and with high pressures. And the X-ray, which showed bilateral white-out lungs, this of course could indicate some pulmonary problems. But most pulmonary problems would have recovered with relatively good respiratory support. At least some improvement would have been seen. So it made us suspect whether we are dealing with obstructed TAPVC. Of course, even before we got the echo, we noted that there was severe hypoxemia with metacidosis and relatively normal carbon dioxide. So all these were important markers of cardiac cause of cyanosis. So broadly, cardiac cyanosis can be because of congenital heart defects where there can be decreased pulmonary blood flow, wherein there is RV outflow tract obstruction, or you may have conditions with increased pulmonary blood flow, which also are called as admixture lesions. And then you can have a condition like TAPVC, wherein cyanosis is because of severe pulmonary venous obstruction. Whereas non-cardiac causes can be respiratory problems, severe pulmonary diseases. There can be persistent fetal circulation, also called as persistent pulmonary hypertension of newborn. CNS disorders, which may result in apnea or hypoventilation and hence cyanosis, and other causes, miscellaneous causes, we have conditions like methemoglobinemia. So while one approaches a newborn with cyanosis, start by confirming the presence of central cyanosis, which may require the measurement of saturation, a very objective way of commenting that the baby has cyanosis. Clinical evaluation, so which includes a thorough physical examination. In an older child, we would also be able to look for things such as clubbing. In a newborn, one needs to do a thorough cardiovascular system evaluation, including the location of the apex sound, the first and the second heart sounds, the presence of additional murmurs, the presence of hepatomegaly, the presence of signs of respiratory distress, such as tachypnea, Silverman-Anderson score, etc. This is supplemented by investigations such as a blood gas, chest X-ray, the occasional use of hyperoxia test. Although this is an obsolete test, nobody does it in its traditional form. We eventually end up doing hyperoxia test inevitably when we start providing respiratory support for this baby, and we would know whether the baby is responding or not. And eventually, this helps us to arrive at the diagnosis and the management. So some of the clinical clues that indicate pulmonary causes for cyanosis include the presence of respiratory distress. So if you find a baby who just has cyanosis in the absence of respiratory distress, we may be dealing with a condition like critical pulmonary stenosis or TGA. So cyanosis, in fact, severe cyanosis, absolutely no distress. You may still find in a newborn with critical PS, DTGA with intact septum. So here, the only sign that may bring the baby to the hospital would be the low saturations, or if the baby has already got discharged from the hospital, the family might have noted that the baby's lips and peripheries are looking blue. The presence of lung signs like crepitations are usually associated with pulmonary problems, but this can also be seen with conditions that result in pulmonary venous hypertension or pulmonary edema. Cyanosis in parenchymal problems, pulmonary problems is usually mild and it might be uniform, whereas if you see differential cyanosis, it is usually seen in a PDA that is shunting right to left. Responsiveness to oxygen is usually present with pulmonary problems. So if you start giving oxygen or start supporting the baby with PEEP, pressure in the form of CPAP or mechanical ventilation as per the clinical status, usually most parenchymal problems would improve, whereas we might not see any response in cardiac causes like we just saw in this baby with obstructed TAPVC. And cyanosis may sometimes worsen with crying in cardiac conditions. Now, another important DD is respiratory causes, as we all know, might present soon after birth. For example, RDS, meconium aspiration syndrome, or early onset sepsis pneumonia, the babies would become symptomatic right from birth, whereas cyanosis in most cardiac problems may appear a little later. The conditions that may present very early with cyanosis might include a DTGA, particularly TGA with intact septum or hypoplastic left heart syndrome. Now, the other subsidiary findings would be that if you find acidosis, which is associated with an elevated PaCO2, this usually indicates a pulmonary pathology, which affects the baby's gas exchange. In most of the cardiac conditions, we will find a normal or sometimes even low PaCO2 because babies tend to hyperventilate. And of course, the classical hyperoxia test, which is rarely done, but we indirectly end up doing this test when we provide respiratory support for our babies. So hyperoxia test, as you all know, is if the baby is given 10 minutes of 100% oxygen. This might be given either with hood oxygen with all the portholes closed, or if the baby is already on ventilation, you may simply increase the FiO2 to 100%. So if this results in significant improvement in the PaO2 by a level of more than 150 millimeters of mercury or absolute levels of more than 250, the baby is considered to have a past hyperoxia test, and this happens with pulmonary parenchymal pathology. Whereas if PaO2 remains persistently low despite giving 100% oxygen, then this is usually indicative of failed hyperoxia test. There may be some conditions which are equivocal, wherein there can be a marginal increase in the PaO2, wherein it might improve to levels of up to 100 or 150 millimeters of mercury with 100% FiO2. And this typically happens with admixture lesions like hypoplastic left heart syndrome and even with PPHN, persistent pulmonary hypertension of newborn. Now, having discussed about cyanosis, I thought I'll put in a word about pulse oximetry screening, because we all deal more often with normal babies than with babies with congenital critical heart disease. Every newborn who is getting discharged from the hospital must have a pulse oximetry screen. This is typically performed at more than 24 hours of postnatal age or before discharge. So how do you do this? Very simple. You connect the pulse oximeter to A, the right upper limb, which is preductal limb, and B, to either foot. So either of the lower limbs. Now, if you find that the saturation in all the limbs is more than 95%, and if there is less than equal to 3% difference between the pre and postductal limbs, it is considered as normal. Whereas if SATs are between 90 to 94%, or if there is a more than 3% difference in pre and postductal saturation, or if at any point of time saturation is going to be below 90%, then this is considered as failed hyperoxia test. Sometimes we may want to couple hyperventilation along with hyperoxia test, because when we do hyperventilation, it can result in CO2 washout and pulmonary vasodilatation, which can decrease the right to left shunt at the atrial or ductal level. And this can be used to differentiate PPHN from some critical congenital heart diseases. So if you're having a doubtful hyperoxia test, a hyperoxia hyperventilation test can be added, which will result in clinical improvement in hypoxia in PPHN, but it will not result in improvement, or rather it can result in worsening in HLHS. Now, X-ray is the other modality that is helpful in concluding the differential diagnosis in CCHD. So this is how a normal X-ray, which is not rotated, looks like. You can appreciate that these are all the structures that essentially contribute to the cardiac shadow. So the right heart border is essentially comprised of the right atrium. Sometimes you may see the double density created by the left atrium here and the ascending aorta, whereas the left heart border is formed by the aortic knob or the arch of the aorta, followed by the main pulmonary artery here. We will see a small indentation of the left atrium, and the rest of the cardiac left border is contributed by the left ventricle. So these are some normal vascular markings that we can make out. Normally, we will see that there is gradual tapering of the pulmonary vessels as we move from the medial to the lateral third. Now, how does X-ray help us in differentiating different causes of cyanosis? So if you have a condition with decreased pulmonary blood flow or TOF physiology, tetralogy of Fallot physiology, you will have an X-ray looking like this, which has dark or oligemic lung fields with thinned out peripheral vessels. This kind of X-ray is typically seen with critical pulmonary stenosis or tetralogy of Fallot, either the typical type, which is VST with pulmonary stenosis, or other TOF-like lesions, which may include VST-PS, DORB VST-PS, atrioventricular septal defect with PS, TGA VST-PS, etc. So any of these conditions, when associated with the right ventricular outflow tract obstruction, they result in an oligemic-looking lung, and the baby presenting to us with cyanosis, with typically mild or no respiratory distress. On the other hand, if you have a baby with cyanosis coming to you with increased respiratory distress in the form of tachypnea or retractions, and if you find an X-ray like this, where you have prominent pulmonary perihilar vascular markings, prominent hilar pulmonary arteries, you may sometimes be able to see a prominent right descending pulmonary artery, which is dilated here, and pulmonary artery might be traceable onto the lateral third of the lung. So this is typically seen in cyanosis with increased pulmonary blood flow, as can be seen in transposition physiology, in complete TGA or DORB with subpulmonic VST. And based on the level of admixture, whether it is happening at the atrial level, left atrial level, or at the ventricle level, you may be further be able to classify different types of cyanotic congenital heart disease. In a baby with pulmonary venous hypertension, typically seen as in the example we saw, obstructed TAPVC, we may be able to see the curly A and B lines and fluid in fissures, which is indicative of pulmonary venous hypertension. Whereas in a bigger child with pulmonary arterial hypertension, which may even happen with large left to right shunts, we may be able to see a prominent main pulmonary artery. And we have typical X-ray findings in some of the common critical congenital heart diseases. You know that this is the snowman appearance, which we see in TAPVC, non-obstructed TAPVC. Box-shaped heart can be seen in Epstein's anomaly. Agon side is seen with DTGA, and Corey-Sabo or boot-shaped heart in tetralogy of Fallot. Now, ECG, especially the axis determined in ECG, as well as the hypertrophy, which can be seen in some conditions, can help us to kind of determine the possible etiology. So, for example, if you find the axis, you all know that normally in a newborn baby, the axis is slightly to the right. So if you say normal axis in an adult is around 50 to 60 degrees, in a newborn baby, the axis might be around 110. The average mean axis might be in the right side. So based on the direction of the QRS wave in the lead 1 and AVF, we can determine quickly what is the axis. So if both of them are positive, then it is the typical axis. Whereas if you find that both QRS in 1 and AVF are moving away from each other, then this is indicative of left axis. If both of them are moving towards each other, then this is indicative of right axis deviation. So, and you have different other parameters to say whether there is chamber hypertrophy. So in combination, findings on X-ray and some findings in the ECG, particularly the presence of axis deviation might be very helpful, particularly if you see LV dominance and left axis deviation in a baby with cyanosis, you suspect tricuspid atresia. Of course, further evaluation is done with echocardiography and other investigations as indicated by the clinical status. Now, as practicing PGs and doctors, pediatricians, we all need to know what is the role of prostaglandin E1, which is a life-saving drug in any neonate with a failed hyperoxia test. Please to remember that echo is not mandatory for using prostaglandin because this is a life-saving infusion and there are very few conditions that may actually worsen when we start PG1. So this is indicated in any duct-dependent systemic or pulmonary circulation at a dose of 0.05 to 0.1 mics per kg per minute. Keep ventilation ready when one has to start PG1 because 10 to 15% babies may develop apneas. Very few conditions, particularly ones which have a restrictive patent foramen ovale, HLHs, or mitral atresia with restrictive PFO can result in clinical deterioration with PG1 because when the left atrial inflow suddenly increases and PFO is restrictive, the baby can develop signs of left atrial hypertension. Likewise, in obstructed TAPVC, also prostaglandin is contraindicated. So I'll quickly go through this last case, which was a term baby, breastfed until 24 hours, birth weight 2,700 grams, and was noted to be cyanosed with SATs of 70%. Again, normal cardiovascular examination, normal CVS examination in a newborn might indicate some of the very serious illnesses like critical PS, DTGA, and sometimes you may have pulmonary atresia with intact septum. All of these can present with absolutely no murmur. So one should never relax when we find a baby who has no cardiac murmur but is yet cyanosed. So baby had no respiratory distress, clear lungs, abdomen soft, and you can appreciate now with this X-ray that this baby has oligemic lung fields, and this is a RV apex. We can say it's looking like a boot-shaped heart. A LV apex would look like this. So this baby turned out to have pulmonary atresia with intact septum. So I thank our team for helping me put together the presentation, and we have more such lectures which you can access on our online platform, Cuddles Online Neonatology Education. These were some of the newborn babies with congenital critical heart disease that were successfully operated and discharged by our team from KIMS Cuddles with Dr. Anil Dharmapuram sir, our cardiac surgeon, Dr. Nagarajan sir, our pediatric anesthetist, and Dr. Sudeep Verma, pediatric cardiologist. This was a case of TGA with VST as well as AST with single coronary artery. And this was another newborn who was operated on day 1 for a large omphalocele and severe coarctation of aorta. Thank you so much for your patience, and I'll hand over back to Dr. Avinash.
Thank you, ma'am. That was an enlightening presentation. We got a valuable insight from the presentation. So thank you for your time, ma'am.
Thank you, Dr. Avinash.
So next presentation is by Dr. Suman. The topic is pulmonary arterial hypertension and crisis. So Dr. Suman is a pediatric intensivist in KIMS Gachibowli. And over to Dr. Suman.
In next 20 to 30 minutes, we'll be going to talk about pulmonary arterial hypertension. I am Dr. Suman, pediatric intensivist at KIMS Cuddles Gachibowli. So in what we are going to talk about is basically what is PAH, how do we classify them, what is the pathophysiology behind it, and how does they present to you, and what are the diagnostic evaluation you might do, and how do you manage in a PAH. So basically I'll be talking more of a PH crisis in pediatric ICU rather than PPH of a newborn. So what we all know is PAH is an abrupt or sustained, one second sir, I'll just
Dr. Suman, any issues?
Yes, sir. This is obstructing my. It's obstructing the slides. I'll see, sir. 1 second. right? So PH is an abrupt or sustained increase in pulmonary vascular resistance with suprasystemic elevations of pulmonary arterial pressures. So it should be abrupt, should be sustained, and which is suprasystemic. So which can lead to fulminant RV failure, leading to low cardiac output state. Sometimes it leads to cardiac arrest and death. There might be a number of triggers that can cause, be it in infection, post-operative procedures, pain, or a new onset of lung disease. All this can trigger your pulmonary hypertension. So
Suman, your voice is not audible.
Not
Now
audible.
it is coming.
Okay.
Yeah.
So the previous definition is mean pulmonary arterial pressure more than 25 is called pulmonary arterial hypertension. And recent changes making it to, in 2018, it has been changed to more than 20 mmHg. To which, if it is pre-capillary, your pulmonary capillary wedge pressure should be less than or equal to 15, and pulmonary vascular resistance should be more than or equal to 3 Wood units. If it is post-capillary, just your pulmonary capillary wedge pressure should be more than 15 mmHg. So what is the basic physiology behind it? So to know it, we should talk about two important aspects, that is pulmonary vasculature. The second is a right ventricle. So basically you have a vasoconstriction of the pulmonary vessels with inflammation, causing a remodeling of pulmonary vessels with the in situ thrombosis, and there will be a vascular growth also, to which there will be significant vascular constrictions. If you see this picture, you have an imbalance between agents that cause vasodilatation and agents that cause vasoconstriction. Thereby, you have a significant vasoconstrictions when you have these vasodilatory agents being less and vasoconstrictive agents being high, causing smooth muscle contraction, leading to pulmonary arterial hypertension. So this pulmonary arterial hypertension, if you see into the much details, you have a hypoxia, there will be potassium influx and there will be increased calcium, leading to vasoconstriction. So what happens if there is increased pulmonary vascular resistance? So this increased pulmonary vascular resistance will cause increased RV afterload. So if you have increased RV afterload, your stroke volume will be reduced. Your right ventricular end diastolic volume, because certain amount of volume might not be going out of the right ventricle because of your increased pulmonary vascular resistance. So increased right ventricular diastolic volume will be high. So because of which you might slowly develop something called right ventricular hypertrophy if it is a chronic. But if it is in an acute phase, what happens? There'll be neurohumoral response, like a RAS system will be activated. Because of this, you will have a fluid retention, and they're causing increased right ventricular blood volume. Because of this increased RV blood volume and increased RV afterload, your interventricular septum starts, which is towards the right side, will make it to more of flattening, and slowly it will move to the left side, causing your left ventricular left ventricular filling will be compromised, and left ventricular cardiac output will be compromised, leading to low cardiac output state. I hope I am clear on this physiology. If not, I'll show you a picture again where we can talk more on that. So the similar aspect. That is very important for us to understand how a right ventricular, how a pulmonary vascular resistance is going to affect your right ventricle as well as left ventricle, causing a low cardiac output state. So if it is a pulmonary vascular resistance, what happens in congenital heart disease, where you have both the pre-tricuspid and post-tricuspid lesions? If you have a post-tricuspid lesions like a VST, because of the shunt, there will be movement from the left to right, where the pulmonary pressures will be equal to systemic pressures. And once, if you are not treating, then your pulmonary vascular resistance will be suprasystemic, leading to Eisenmenger syndrome. So this is about the physiology. A PPHN I will not discuss. If you see the classification, this is the WHO classification, where it has given 5 classification, where 5 I will not discuss. So pulmonary arterial hypertension, the per se nomenclature comes to only the class 1 of this, only this one will come as a pulmonary arterial hypertension. You see your connective tissue disorders, portal hypertension, congenital heart disease, and your HIV infection, all these lead to pulmonary arterial hypertension where your inodilators do work. So this is another classification by Panama, which answer. This is about the definition, physiology, and the classification. And how does a patient present to you? They present in 3 different scenarios predominantly. One is a type 1 PAH presenting with a crisis, like an idiopathic PAH or sickle cell disease presenting you as a PAH crisis. Second, you have a chronic lung disease with a type 3 PAH, like a severe BPD, now has developed a new onset pneumonia, now presenting to you as a PAH crisis. Or a post-operative congenital heart disease presenting to you as a PAH crisis. These are the common different scenarios by which a child can come to you as a PAH crisis. So there will be other triggers that can cause PAH, where arrhythmia, myocardial ischemia, new onset of infection, embolism, all leads to increased pulmonary vascular resistance. So when you have increased pulmonary vascular resistance, which is more than 40, that is poorly tolerated by the right ventricle. As I said previously also, your compensatory mechanisms will fail. And because of this, then you'll have RV dilatation, RV failure, or left shift, septal shift will be onto the left side, causing LV compression, causing hypotension, causing your low cardiac output state. And during this phase, your coronary perfusion also will be compromised, both your right ventricle onto the left ventricle also. Because of this low cardiac output state, they will be resulting in metabolic acidosis. Again, metabolic acidosis will further increase your pulmonary vascular resistance and pulmonary arterial pressures. The same thing which I was telling you. So because of this, your right ventricular, because of increased PVR, you will have right ventricular diastolic pressures will be increased right ventricular end diastolic volume, leading to right ventricular ischemia because of low coronary perfusion, and your right ventricular stroke volume will be decreased, your pulmonary bed flow will be decreased, and this causes septal shift causing LV compression, thereby which your LV stroke volume will be compromised, and LV also will go into ischemia. So because of this, your systemic blood pressures will be compromised, leading to low cardiac output state. So causing to acidosis. So if you see clinically any child of PH crisis, they present to you as a hypoxia, and most common symptoms that you might see is a signs of low cardiac output state. That is reflected to you as an altered sensorium, lactic acidosis, hypotension, AKI, or liver injury. So, and the other signs would be because of increased right ventricular systolic pressure or right ventricular hypertrophy, you might see TR murmur, rise at JVP, enlarged liver, and loud P2. Because of RV failure, the child can have either tachycardia or bradycardia with S3 gallop, hepatomegaly, or ascites. So how do you identify? This is the clinical manifestations of a PAH that you can see in the child. So how do you diagnose this, or what are the other support evidence to think in this? If you have an ECG, it will predominantly show signs of RA dilatation or right bundle branch block, or you might see right ventricular strain pattern or right ventricular hypertrophy pattern. And in an X-ray, at times, most of the times, actually, it doesn't much of will not much help you. But at times, you might see your pulmonary arteries being little what do you call enlarged pulmonary arteries. You might see an X-ray. But I see the lung disease causing PAH. You might not see in your X-ray. But yes, we need to get X-ray undoubtedly. So 2D echo. This is one thing which everyone will get it done. If someone is doing a 2D echo, if you are asking your cardiologist to do a 2D echo, so always ask for all these events that what is happening with the child. Do you have an ARIA-RV dilatation? If you have an ARIA-RV dilatation, yes, it can lead to it can have a poor prognosis as well. You have a pericardial effusion, it has got poor prognosis. What is your TR gradient? What is your right ventricular fractional area change? What is your interventricular septal position? What is your TFC? How much change it is happening, and how much? What are the shunts you have in this too, in this cardiac echo? That these are the things you ask for your cardiologist to see. So this is something, and following which evaluation of cause. So always an infant who comes to you with cardiorespiratory failure, you've done a basic 2D echo and there is an ARIA dilatation. In our belt, we have also an article which showed that there are many children who are thiamine deficiency. And the moment you give thiamine for those children, there will be a dramatic response in terms of pH. We have seen a number of patients. So consider sometimes, thiamine deficiency is one of the cause for a severe pH in small infants, nutritional deficiency. In a stable patients, to look for a parenchymal disease, you might do HRCT. To look for pulmonary thromboembolism, you might need a CT pulmonary angiogram. As a cardiac, to look for shunts, a portosystemic shunts. Your hypoventilation syndromes also can cause your PAH. There will be, and these days we do lot number of genetic where you are not finding an evidence for why the child has developed PAH. You look for genetic causes as well. And this one marker, NT-proBNP, has been studied well, and it has been a reliable marker to say in your PAH, the NT-proBNP levels will be high. So coming to the management of pulmonary hypertension, so it starts with the supportive management. As it's like high risk inpatient. We'll talk more about the how do you intubate a child of pulmonary arterial hypertension. So as I said, if you ask me, intubating in a pulmonary arterial hypertension child, severe PHL, is one of the toughest intubation that we can do physiologically. Now, the moment you start giving good sedation, if you are not giving sedation properly or you are intubating improperly, there is a high chance that either pre-intubation or post-intubation, the child can develop a cardiac arrest. So how well we can prepare ourselves to intubate a pulmonary hypertension child is very important. So there are recently now we can connect our inhaled nitric oxide through a nasal cannula or HFNC. Through HFNC, we can even detect how much ppms of inhaled nitrics can be given. Even the ppm can be also be seen. Always optimize your preload and afterload. If you have a low preload because of significant vomitings and dehydration, give some fluids. If you have a significant afterload, then give some diuretics looking at the fluid volume status. And sedation wide, fentanyl and kintabin had got a good effects on pulmonary vascular resistance. So these are the preferred agents for induction. And you can always try to use a fast acting muscle relaxants, probably a rocuronium or a glucuronine should be helpful to us. And while intubating the child, so you should do bag and mask. The one important aspect is avoid prolonged apnea. Because of this CO2 retention, it can worsen your acidosis and worsens your pulmonary vascular resistance. Have a very good sedation, because your pain, anxiety would increase your pulmonary vascular resistance, leading to further crisis. So always prepare for cardiac arrest, have bicarb with you, have adrenal boluses. If that happens, yes, you should have an ECMO also as a backup. It might not happen in many centers. Yes, but ECMO is also one of the backup should be. If you are intubating a child of severe PH, you will inform your team or the other hospital which has an ECMO facility. So the basic general principles of the treatment is you induce pulmonary vasodilation. You unload the pressure and support your right ventricle. Avoid the coronary ischemia and heart failure. Improve so that your clinical symptoms will be increased. When you talk about pharmacotherapy, if you have done cardiac catheterization, I have not touched about cardiac catheterization. If someone has done cardiac catheterization for a child and which was found to be vasoreactive testing, you do vasoreactive testing with calcium channel blockers. If it is a responder, you'll use calcium channel blockers. That is for absolutely stable patients. So we have a non-responders. There are three main pathways that are involved. One is prostacyclin pathway based treatment, endothelin based pathway treatment, and nitric oxide based pathway treatments. Your nitric oxide pathway based treatment oral is sildenafil, phosphodiesterase 5 inhibitors. Your endothelin receptor based pathway is bosentan. Whereas your prostacyclin based is epoprostenol, treprostinil, and iloprost. The recent drugs are micutentan and riociguat, which are not FDA approved for pediatric, and its availability in India is also scarce. These are the different landmark trials in pulmonary hypertension comparing IV prostanoids, sildenafil, and bosentan for placebos. So if you have non-pharmacological therapy is like you make an intra-atrial communication for a severe PH patients. So this is if you have a native pulmonary arterial hypertension. So what are the treatment modalities? So there is a huge controversy to use only sildenafil or sildenafil plus bosentan, or you add 3 agents. So I'll not touch upon this area. So I'll just go to the main important aspect, that is acute pH crisis in children who presents to your ICU. So this is a very important slide which we have discussed. Thus, you treat the precipitating factors. You treat your arrhythmia. You correct your anemia. You correct your thrombus. There might be a shunt which has got thrombosed, so you might have a sepsis. So you optimize your RV preload. As I said, you have a high preload, use diuretic. You have very low preload because of any condition, then you use your fluids. Optimize your you reduce your RV afterload by using air prostanoids, ionvo pathways, or by using ionodilators. So you maintain your perfusion pressures by giving a pressor agents. I'll show you what is about that. So improve your RV contractility by giving inotropes and inodilators. So someone comes to your ICU. What are the basic things which we need to do? First, start on oxygen, because this is a very good pulmonary vasodilator. So which will improve your oxygenation and which will prevent your anaerobic metabolisms. So you might give alkalization. So if you have a significant acidosis, you might tend to give a bicarb to improve your pH, which might reduce your pulmonary vascular resistance. You will definitely make the child less anxious. Give sedation so that your pulmonary vascular resistance will be reduced. And coming to the mechanical ventilation and intubation, we have said so many people are in opinion that the moment you intubate the child will go into cardiac arrest, because you intubate, the pulmonary vascular resistance will increase and all this. It's not like that. If this child needs an intubation, the child needs intubation. So there is nothing like if you intubate the child will go into cardiac arrest, nothing like that. In fact, if you maintain your FRC, their pulmonary vascular resistance is least at your FRC. So yes, if the child needs intubation, you need to intubate the child, even if the child is having significant RV dysfunction, taking appropriate measures. So when you are giving any anesthesia, as I said, you are reducing pulmonary vascular resistance. At the same time, your systemic vascular resistance also can fall. So you should have just note on it that your systemic blood pressures also might be falling. You might need a pressor agents. So as I said previously also, hypovolemia, you need to correct it. Excessive volume overload, you reduce it by giving Lasix, or you have at times we might need to use a CRRT also to reduce your fluid overload in resistant heart failures. So with this, I'll just go to inotropics. So if we have a severe RV failure, the inotropic agents that you might use is like you might use a milrinone and levosimendan, which have a positive inotropy effect. It has no effect on heart rate, usually very less effect on heart rate, but it reduces your pulmonary vascular. It produces your good inotropy and reduces your pulmonary vascular resistance. When we are using dobutamine and adrenaline, the problem is like it induces tachycardia and induces your impaired diastolic filling, causing you a low coronary perfusion and can cause low cardiac output. So when we need to think of vasopressors like norepinephrine or vasopressin, as I said, when you are using this multiple agents, there is a systemic hypotension which causes a further shifting. So that is the point at which you can start on your vasopressors. By starting your vasopressor, your systemic pressures will be high, which will cause shifting of your intraventricular septum, which was towards your left side. Now it will shift from left side to right side. So which will improve your left side cardiac output. So all these steps are being failed. Yes, there is always an option of an ECMO. So the same things which I have told. So the recommendations for acute pulmonary hypertension is give oxygen, IV prostanoids. This I will be very honest. I have never used IV prostanoids. I always started on intravenous sildenafil. So if you are intubating the child or you are giving through HFNC, you will tend to give inhaled nitric oxide through it. I said you will start on sildenafil. If someone is on inhaled nitric oxide also, you will start sildenafil. And definitely when you are stopping the inhaled nitric oxide, we must start on sildenafil because it leads to rebound pulmonary arterial hypertension. So acute crisis, always intravenous sildenafil is better over oral thing. And inhaled iloprost is not available in India. The same thing which I have told you. So intravenous epoprostenol I have never used. So this is not available. Inhaled nitric oxide 2 to 40 ppm. Usually we don't go beyond 20. More than 40, there are many studies which had shown no improvement. In fact, it worsens your systemic pressures. Sildenafil IV, use it for use it as a continuous infusion. So these are rest of the agents which we have discussed. So when you are ventilating a child, as I said, we have to see, most of the times you have a cardiac surgeon who has done the surgery, has brought to your ICU, and the child is going into PH crisis. So always do a normalized ventilation. So the point is, in ventilation, you should not, like the way we said, allow permissive hypercapnia. In this situation, we will not allow permissive hypercapnia. We'll do a gentle ventilation, but we don't accept higher CO2s in this situation. Someone ventilator patient is in crisis. Most of the times you might be secondary to your inadequate sedation. Give good sedation, give muscle relaxants that will allow the pH crisis to settle. So always have a minimal handling, minimize suction. So, and that is how you can manage pH crisis apart from your rest of the management in a ventilator patient. In post-plane shunt, you might have a thrombosis where you'll ask your cardiothoracic surgeon and your cardiologist to confirm things, and you might use heparin for the same. So various studies which about this, I'll skip off these things. I thought I'll have some quiz also, but I'll skip off all these things. With this, I conclude.
So any questions regarding the previous presentation, you can ask here.
Parag sir hai?
Is in offline.
Offline.
I'm there.
Sir, have you used IV prostanoid, sir, anytime?
So now the problem with the IV prostacyclin is the half-life is very, very low. It's in seconds. So what happens? Usually IV prostacyclin can be given in 3 ways. One is you can give as an IV infusion, but most of the patient, if you start IV prostacyclin and send them home on IV infusion, it is not possible. So second thing is subcutaneous. So you can have like an insulin, you can have a similar kind of a pump where you can put an IV prostacyclin injection and it will keep on giving below the skin. This is the second thing. Third is again inhalational. The way you give inhaled nitric oxide, similar way you can give prostacyclin. Same prostacyclin where there is no preservative can be given as an inhaled.
Okay.
So
that injection that
also you cannot carry them because it's again a short span of action. So the only recommended at this moment all over the world is subcutaneous pump of prostacyclin.
Okay. Yeah, but use kar liya, sir. I've never seen anyone using.
It's not available. Not available here. I have used it in somewhere else, other places
Okay.
out
It's not
of India.
available. That's what I was wondering. I didn't see anyone using.
Yeah, mainly primary or secondary pulmonary arterial hypertension, those kids who are actually non-respond to bosentan, sildenafil, oxygen, and stiff kind of a pulmonary vasculature, going for lung transplantation. These are the kids, few kids, they receive this.
Yes. Any questions? Chart me, I think there are some questions.
So, very important topic actually, pulmonary arterial hypertension, very important topic. And just one thing, pulmonary arterial hypertension doesn't mean that you have to use so many medications every time, like pneumonia patients, bronchiolitis patient, asthma patient, you'll have some pulmonary arterial hypertension. But whether to treat or not depends upon how good or bad is your right ventricle. What is the primary condition? If the primary condition is improving, you don't have to use other medications, because the primary condition is the reason for pulmonary arterial hypertension. But be sensitive about these things when patient comes, and specifically when you're doing an echo. Remember that every pulmonary arterial hypertension, you are not going to get RV failure or TR jet or anything like that. Initial phase, it could be just interventricular septum which is not moving, it is stiff, and then slowly you will having a right ventricular hypertension, the pressure will keep on increasing, and then you will have a little bit of dilatation, and then you will have some TR jet. So try to identify it early rather than late.
I would also insist on the same thing again, that intubating in a pulmonary arterial hypertension child is a very difficult thing. Always prepare yourself for an elective ventilation. If you are intubating, keep yourself ready for all the complications like cardiac arrest that can happen. So as I said, previous slide also we showed, make sure that you are ready for intubation with all, keeping things ready.
So thank you, Suman. So if there are any no more questions, we'll move on to the next presentation. So the next presentation is on cardiopulmonary bypass and general care after the cardiopulmonary bypass, presented by Dr. Srividya. She is a consultant pediatric intensivist in KIMS Cuddles, Kondapur. Over to Dr. Srividya.
Good afternoon, everyone. I'm Dr. Srividya, consultant pediatric intensivist, KIMS Kondapur. I'm here to discuss about cardiopulmonary bypass and the general care after bypass. So basically, cardiopulmonary bypass is a form of extracorporeal circulation which temporarily takes over the function of the heart and lungs during surgery, maintaining the circulation of the blood and oxygen content, and it facilitates surgical intervention by providing a motionless and bloodless field. So the primary goals of CPB include oxygenation, carbon dioxide elimination, circulation of the blood, systemic cooling, rewarming, and diversion of the blood from the heart to provide a bloodless surgical field. This is a Gibbon heart-lung machine of 1955, the first machine, which was used in first series of open heart surgeries by John Kirkling. More than 30 years of innovation, research, and hard work led to the present bypass machine. The components and of the bypass circuit include venous and arterial cannulas, venous reservoir, centrifugal pump, oxygenator, heat exchanger, microfilter, bubble trap, sucker vent, cardioplegic solution, and suction system, and the occluding clumps. I'll show the different parts in the different diagrams. Basically, venous cannulation is done. It could be bicaval or cavo-atrial approach. It's in IVC or SVC, or bicaval or cavo-atrial approach. And arterial cannula is basically in the arch of the aorta, preferably. And this is the basically arterial cannula where we cannulate. The arterial cannula, and this is the venous cannula in the SVC and IVC, and this is a cardioplegia cannula, which is cannulated in the aortic root proximal to the aortic cannula. And regarding the cardioplegia and all, we will discuss in the coming slides. And this is our heart bypass machine. The parts include this is the sucker pump, and this is the LV vent. This is the cardioplegia pump, and this is the blood pump. This is the screen to monitor the flows, to adjust and monitor the flows, and this is the this is the gas oxygen air blender, and this is the filter, and this is the venous reservoir, and this is the cardioplegia solution system, and this is the main cardioplegia solution system containing the cardioplegia bag, and this is a heater cooler unit. This contains almost basically there are 3 connections, one connecting to the oxygenator, the other connection to the cardioplegia system, and the other connection mainly to the warmer blanket directly to the patient. So this is a line diagram showing how the bypass, how we do the bypass. So basically from the venous cannula, blood is vented out from the venous side to the venous reservoir, then to the systemic blood pump, then it comes to the heat exchanger, and before the after oxygenation, heat exchanger and oxygenator, and before going to the arterial system, there is an arterial filter. At the same time, this is a cardioplegia solution system with a cardioplegia pump which drives the cardioplegia solution to the aortic to the arterial system, and from this cardioplegia solution from the LV, this is vented out, and these are the sucker pumps, and LV vent. Ultimately, this sucker pump drains the blood from the surgical field, and the LV vent usually ventricular residue volume. The LV vent, LV distension is a problem due to the venous blood coming out from the heart. This distension to be avoided by the LV vent. Ultimately, it goes to the cardiotomy reservoir and then to the venous reservoir. And this is the oxygenator. This has a blood gas interface for the oxygen and carbon dioxide exchange. This is the venous reservoir, below which the oxygen and heat exchanger. So basically arterial line filter is the last component which through which the blood passes before it returns to the patient. Usually it removes all the particulate and gaseous microemboli after the bypass, and later the blood is sent back to the arterial system. So how cardiopulmonary bypass differs between infant, pediatric and adult? Usually pediatric, they have a mature organ system, smaller circulating blood volumes and higher oxygen consumption rate, and very reactive pulmonary vascular bed, and there is an impaired temperature control, and they have poor tolerance to the microemboli compared to the adults. And the estimated blood volume is also more in the pediatric cardiopulmonary bypass, and the tolerance for the circulating volumes is also less. And the dilution effects on the blood volume is more. Basically, after the hemodilution during the cardiopulmonary bypass, it almost dilutes to 50 to 200% of the blood volume, and the oxygen consumption is also more. And the minimum cardiopulmonary bypass temperature commonly is kept at between 18 to 28 degrees. That also varies between the adult and pediatrics. And the perfusion pressures required to maintain are between 50 to 70. And the acid-base management during the hypothermia, during the cardiopulmonary bypass, there is a different strategy for the pediatric patients, which is explained in the coming slides. So basic cardiopulmonary physiology includes hemodilution, hypothermia, blood gas control, setting up the flow rates, ultrafiltration, cardioplegia, anticoagulation, and neutralization. And basically prime usually in the adult circuits requires almost 1.5 to 2 liters of balanced electrolyte solution, usually crystalloids, to de-air the circuit completely. And basically priming is does the function of de-airing the circuit and decreasing the viscosity of the blood, and increases the tissue perfusion, and this also further increases the oxygen carrying capacity. And usually to the priming fluid, we add calcium, heparin 3 to 4 units per ml, and other pharmacological agents. And mostly in the pediatrics, priming will be crystalloids along with the packed cells to prime the circuit. And the priming volume change in the pediatrics is calculated according to certain formulas. The blood required on the prime is calculated with the formula target hematocrit into total circulating volume minus patient hematocrit into patient's blood volume divided by hematocrit of the donor. And target hematocrit and bypass usually 21 to 24% in adults and 28 to 30% in the pediatrics. And the pump flow rate is calculated according to body surface area into cardiac index. And what are the advantages of the hemodilution? It reduces the blood viscosity, increases the tissue perfusion, and maintains a good oxygen delivery. But the disadvantages include it reduces the plasma colloid oncotic pressure, plasma proteins, and alters the pharmacodynamics of the drugs, and also decreases the coagulation factors, and causes decreases the concentration and the platelet dysfunction. But extreme hemodilution also causes inadequate oxygen delivery. And hypothermia is induced during the cardiopulmonary bypass to provide organ protection, also decrease the metabolic rate and oxygen consumption. So target myocardial temperatures will be around 10 to 15 degrees centigrade. In the when we do a cardioplegic arrest along with the hypothermia, in the asystolic state, usually the metabolic rate goes down to 0.1 ml per 100 gram per minute. And for every 10 degree drop in temperature, there will be additional 50% decrease in the oxygen requirement. And but the hypothermia, in spite, it decreases the metabolic rate and oxygen consumption. At the same time, it increases the RBC aggregation, platelet sequestration, complement activation, and bradykinin release, which leads to cardiopulmonary bypass complications, which is discussed later. And there are two blood gas strategies which we use, alpha stat and PH stat. I'll not go into detail in this, but usually in the pediatrics, PH stat is the strategy we use. It means like we maintain pH constant at all the temperatures, even during cooling. But this requires addition of the carbon dioxide to the oxygenator while cooling, because cerebral blood flow is to be maintained higher, and the cerebral blood flow is uncoupled to the cerebral oxygen demand in the pediatrics. But this is different from the alpha stat, which is managed in the adults. Their pH is allowed to increase with the cooling and blood becomes alkalotic. But cerebral blood flow there is auto-regulated and coupled to the cerebral oxygen demand. But even in the deep hypothermic arrest, in the complex cardiac surgeries, usually PH stat is switched over to alpha stat, and the blood flow usually pump flow is maintained as per the body surface area into the cardiac index. This is calculated according to the age. And ultrafiltration, this is the last part in the CPB circuit, where this reverses the hemodilution during the cardiopulmonary bypass initiation. And it decreases the post-CPB edema, which improves the tissue perfusion, oxygenation, and at the same time, it removes the vasoactive substances like C3A, C5A, all this, and along with that, this also removes the microemboli before returning blood to the arterial system. And coming about the anticoagulation, usually Before arterial and venous cannulation, IV heparin is given at 300 to 400 units per kg, and ACT is measured 3 minutes after the dose, and they should be maintained more than 480 to begin the cannulation. In between, ACT is checked every half an hour, and this may need sometimes FFP for the antithrombin levels. And while coming off the bypass, neutralization should be done with the protamine. 1 mg is given per 100 units of the heparin. So what are the sequence of events in cardiopulmonary bypass? Circuit selection, priming, anticoagulation, cannulation, initiation and maintenance of cardiopulmonary bypass, myocardial protection, weaning and termination from the cardiopulmonary bypass. So this conduction of the bypass is conducted in the 4 steps. Setting up of the circuit, priming, heparinization, going on bypass, checking bypass parameters if satisfactory, cardioplegia, arresting the heart. Then weaning comes in 4 steps: rewarming, de-airing, pacing, and checking criteria for the weaning, gradual coming down if satisfactory, stopping the circuit. Then priming this we will not discuss in later. I'll just switch over, run over the slides. Basically, venous and arterial sites are in continuity, and usually priming is done to de-air the circuit, and priming solutions will be crystalloids and the blood, and sometimes colloids are also used. And later on, after priming, the heparinization is done, which I already discussed, and we maintain ACT more than 480 before going on, before starting the cannulation. And this is the circuit, setting of the circuit. Venous and arterial end continuity is cut. This is the venous cannulation. This is the arterial cannulation, and the venous, arterial along with the cardioplegia cannula kept. Then going on bypass, before dividing the venous and arterial lines, usually pump will be off and the venous line is clamped. Later on, before connecting the lines to the cannula, we ensure that circuit is de-aired, and for confirming the circuit is de-aired, and for confirming the satisfactory bypass, usually the following parameters are checked: mean arterial pressure, oxygen saturation, whether the cannula, there is no evidence of dissection or anything, and A-line pressure and pump flow rates should be checked, and for the drainage, whether the heart right atrium is decompressed, and central venous pressures, and also the reservoir, whether it is adequately filled. And then if both perfusion and drainage are satisfactory, then we will go for the myocardial protection strategy, that is cardioplegia. And this myocardial protection. What is myocardial protection or cardioplegia? Usually for intracardiac repair, we need cross clamping of the aorta, which renders the heart ischemic. Hence, cardioplegia is required to provide a motionless feel for the surgeon. So to arrest the heart in the diastole, we use the potassium enriched cardioplegia solutions. And potassium induced arrest, it reduces the myocardial oxygen consumption. Along with the cardioplegia solution, hypothermia reduces the myocardial oxygen consumption by 97%, which enables the tissues to withstand the interruption of the flow during the surgery. So it could be cardioplegia can be delivered through the cardioplegia cannula in the aortic route or through the coronary sinus. Usually we use Del-Nido cardioplegia solution, which contains the plasmolite, sodium bicarbonate, mannitol, magnesium sulfate, lignocaine, and potassium chloride. So what are the things we need to monitor during bypass? We need to continuously monitor ECG, perfusion pressure, central venous pressure, arterial pump flow rates, suction pump flow rates, core temperature, and intermittently the other parameters to be monitored are pH, ACT, random blood sugar, potassium, LA pressures, urine output. So the desired ACT should be more than 480, and the systemic flow rates, this is according to the age. And central venous saturation should be more than 70%, and hematocrit target around 28 to 32 in the pediatrics, and glucose around 100 to 180. So how do we wean? Weaning from the bypass, basically with the de-airing, rewarming. Usually rewarming should be done usually temperature should be increased at gradual rewarming should be done 0.3 to 0.5 degrees per minute. Then over rewarming also denatures the proteins. And how to confirm the suitability for weaning. Before weaning, we should confirm that there is no residual air in the system. Also, there will not be any residual lesions. And physiological temperature 35 to 37 degrees is reached, and ABG and potassium, everything needs to be monitored. And there is a satisfactory pacing and satisfactory ventilation. And gradually, gradual clamping of the venous line and the pump head to be switched off, and cannulas will be out. So what are the complications due to cardiopulmonary bypass? So basically, cardiopulmonary bypass time includes pre-clamp, aortic clamp time, and reperfusion time. And aortic clamping time and total cardiopulmonary bypass time has a lot of significance. Aortic cross clamp time more than 60 minutes and cumulative cardiopulmonary bypass time more than 180 minutes increases the risk for low cardiac output, prolonged ventilation, prolonged ICU stay, renal complications, and increased 24 hours post-operative blood loss requiring multiple transfusions. Basically, this cardiopulmonary bypass usually causes the effects because of the pathophysiological mechanism. This is due to the blood and circuit surface interaction and ischemia, reperfusion, injury, and hypothermia, which causes the after effects of the cardiopulmonary bypass, like coagulation. A fibrinolytic kallikrein complement system are activated, which leads to cell endothelial activation and cytokine release, which further increases the capillary permeability and leads to multi-organ dysfunction. So, for the 5 principal pathophysiological effects which occur during cardiopulmonary bypass are bleeding, thrombosis, vasodilatation, capillary leakage, and susceptibility to infection, which leads to multi-organ dysfunction. So what are the post-op complications associated with the cardiopulmonary bypass are due to the problems from cannulation, cross-clamping, the time of exposure to the CPB circuit, and accessing the chest and collapsing the lung, and exposure to the drug, blood products, hypothermia, which causes arrhythmias, myocardial depression, and altered pharmacokinetics. So what are the things we need to monitor post-bypass? The core and peripheral temperature, urine output, drain output, fluid status, mean arterial pressure, CVP, ECG for the rhythm issues, and central venous saturation for the low cardiac output thing, and ETCO2, arterial blood gases for the lactates and also the CO2, and electrolytes, blood glucose, ventilation parameters, the peak pressures and FiO2 requirements, sedation, pain, and muscle relaxation to be managed. So basically, mechanical complications can occur during arterial cannulation by cannula malposition, or due to the during arterial cannulation, there can be bleeding or cannula malposition or aortic dissection. During venous cannulation, there could be airlock or massive air embolism can occur due to pumping from an empty reservoir. Other things will be oxygenator failure or pump malfunction. The systemic complications involve all the systems like hematological, cardiovascular, respiratory, neurological, and renal. Hematological complications are mainly due to the activation of the coagulation complement and kallikrein system leading to fibrinolysis. And hemolysis mainly due to the systemic inflammatory response syndrome and mechanical destruction by the pump. And due to the hypothermia, there will be hypothermia, hemodilution all causes the coagulopathy. And due to SIRS response, there will be platelet dysfunction, platelet aggregation, and thrombocytopenia. Bleeding can occur during cannulation or post-bypass or due to hypothermia or due to incomplete reversal with the protamine. So what are the risk factors for the post-operative bleeding? Younger age with complex cardiac lesions requiring deep hypothermic cardiac arrest. Mainly, what are the points of concern? Bloody drains more than 10 ml per kg per hour in the first 2 hours or 4 ml per kg per hour after that, or sudden increase in the drains, or clots in the drain, or sudden drop in the hemoglobin, rapid fall in the cardiac filling pressures monitored by LA pressures and CVP, or evidence of cardiac tamponade, which is suspected by sudden jumping of the CVP and dropping of the blood pressures and sudden desaturations and decreased urine output. Mainly cardiac tamponade is caused by the fluid collecting in the pericardial sac, which usually impedes the diastolic filling, diastolic relaxation and cardiac filling. So basically open cardiotomy is done to remove the fluid and therefore the pressure. Management of the post-operative bleeding. For the prolonged ACT in the first 2 hours post-surgery, protamine we gave 1 mg per kg over 15 to 30 minutes. But beware of the hypersensitivity reactions and hypotension induced by the protamine. And target platelet count more than 1 lakh. Vitamin K, FFP are given. And packed cell transfusion are given, targeting hemoglobin more than 10 and at least more than 12 in cyanotic heart diseases. And tranexamic acid infusion slowly is begun over half an hour at a dose of 10 mg per kg when there is fibrinolysis and all. And activated factor 7 is the last option, which is given at a dose of 15 to 30 microgram per kg per dose. And if low fibrinogen levels, cryoprecipitate is given. Apart from that, control hypertension and also the adequate sedation, paralysis, and muscle relaxants. So what are the effects on cardiovascular system? Arrhythmias due to hypothermia, nodal rhythm due to myocardial edema and junctional ectopic tachycardia, low cardiac output, myocardial stunning, myocardial ischemia, RV dysfunction due to protamine-induced pulmonary hypertension while coming off the bypass, and vasoplegia due to activation of the nitric oxide synthase and ATP-sensitive potassium channels and relative deficiency of the vasopressin and CIRS response. So low cardiac output state, how is it characterized? I will not go into detail. This will be dealt in the next coming topic. So urine output less than 1 ml per kg per hour, cool extremities and capillary refill time more than 4 seconds, and decreased pulse pressure, tachycardia, altered level of consciousness, decreased blood pressure, and low central venous saturation. Apart when there is a low cardiac output, always check for the bleeding and drain outputs and central venous saturations. So why does low cardiac output state occur? This is because of the bypass and operative considerations, like there will be hypermetabolic state with tissue supply and demand imbalance, and metabolic uncoupling energy failure due to causing mitochondrial dysfunction and ultimately myocardial dysfunction. And there could be systemic or pulmonary vasoconstriction, systemic vasoconstriction due to hypothermia, increased circulating catecholamines, and pulmonary vasoconstriction after chest closure and endothelial injury. This and also due to hypovolemia, due to bleeding, capillary leak. This ultimately lead to myocardial dysfunction. And operative considerations like ischemia, reperfusion injury during cross clamping, and inadequate cardioplegia leading to inadequate cardioplegia, or myocardial edema during ventriculotomy leading to AV block and junctional rhythms. Leading to myocardial dysfunction. Apart from this, residual lesions or pre-existing cardiomyopathy, this also are the contributing factors to the low cardiac output. So how do we manage low cardiac output state? Just support the preload and avoid the fluid overload, and provide adequate sedation, analgesia, and lung protective strategies. Improve the contractility with epinephrine, inotropic agents. Once BP a bit stabilized, we can add inodilators like milrinone, and decrease the pulmonary vascular resistance with inhaled nitric oxide. And the low cardiac output state, which is refractory to all the medical interventions, again go for ECMO. Junctional node. This occurs usually due to ventriculotomy and myocardial edema during the operative thing. So junctional rhythm is characterized by the narrow QRS complexes with regular PR interval and absent hidden buried P waves under QRS or P waves occurring after the QRS. So the rates usually will be around 60 to 80. And treatment usually we do overdrive pacing to maintain the rate at a higher rate and to maintain the contractility. Junctional ectopic tachycardia. There's a malignant rhythm caused by trauma to the AV node or bundle of His or due to myocardial reperfusion injury and myocardial edema. This usually P waves will be after the QRS inverted or absent P waves with a faster rate around 160, more than 180 ideally, and atrioventricular dissociation occurs and there will be a low cardiac output which follows. So for this, usually cooling to 35 degrees with adequate pain and sedation management and overdrive pacing with atrial pacing will be done. And apart from that, good sedation, proper ventilation strategies. Myocardial stunning is the other thing due to direct effects of cardiotomy and cardioplegia. And RV dysfunction and pulmonary hypertension can occur during due to protamine during reversal. This is characterized by acute rise in the pulmonary artery pressure, which ultimately leads to reduction in the cardiac output and fall in saturation. So sedation, 100% oxygen, and muscle relaxant and use of iron done. So the other effect is vasoplegia. This due to SIRS response. It occurs due to the activation of the nitric oxide synthase and smooth muscle ATP sensitive potassium channels activation and relative deficiency of vasopressin. So mainly fluid resuscitation and giving vasopressors like norepinephrine and vasopressin. And methylene blue can be given. Mostly adult studies are there on this. This acts as a competitive inhibitor of nitric oxide and can be used as a rescue drug in severe vasoplegia. So what are the effects on respiratory system? Mainly acute lung injury or ARDS secondary to the SIRS and neutrophil activation. There may be VQ mismatch and lung collapse due to failed expansion, and there can be increased pulmonary vascular resistance due to protamine. Again, management will be optimizing the ventilation, fluid restriction, and adequate sedation and paralysis. What is the cause of SIRS response? Due to exposure of the blood to the bypass circuit, there will be activation of the WBC complement clotting cascades, and this ultimately leads to capillary leakage, acute lung injury, hypotension, renal failure, and coagulopathy. So SIRS response usually occurs within the 24 hours, but whatever fever or hypotension and persistent thrombocytopenia which occurs after 24 hours, usually we exclude SIRS response. Only that thing will be below 24 hours. After 24 hours, if there is high fever, persistent hypotension and thrombocytopenia, always think about sepsis. So management will be lung protective ventilation strategies, blood products if required, inotropic support, vasopressors, and fluid restriction. How do we prevent this SIRS response? It can be by reducing the bypass time, leukocyte filtration, retrograde autologous priming, like the patient's own blood is given for the priming through the arterial line, and this can reduce the hemodilution and ultimately can reduce the SIRS response. Ultrafiltration, this is other modality, and steroids, which remain controversial. So neurological system, how it affects basically seizures, disorientation, confusion, ischemic infarcts, and cerebral hemorrhage. This all can occur post bypass. Carefully, we need to monitor the coagulation parameters by ACT or thromboelastogram, maintain adequate cerebral perfusion pressures and fluid management, and regular monitoring of the PCO2 and PO2, and maintain central venous saturation around 70%, reduce manage low cardiac output state. And renal will be affected by renin, angiotensin, aldosterone activation and vasopressin release. And if there is a prolonged hypothermia, there could be decreased tubular reabsorption and diuresis. And acute tubular necrosis can occur due to prolonged ischemia and which leads to oliguria. So always regularly monitor the renal parameters and also strict input-output chart and adequate fluid management, careful fluid management, if required peritoneal dialysis and hemodialysis. Thank you.
So thank you, ma'am. Thank you for your presentation. So any doubts you can put here in the comment. So tomorrow we have a workstation on CPB and ECMO. So all these doubts will be clarified there, and we'll move back to the next presentation. And then the next presentation is on management of various physiological shunts in post-op cyanotic congenital heart disease. The presenter is Dr. Lingaswamy, who is a pediatric cardiologist in KIMS Sunshine, Begumpet. Thank you. Over to Dr. Lingaswamy. So fine, we'll start the presentation. So there was an technical error in the previous presentation. We'll sort it out and we'll get back to the same presentation. So for the next 30 minutes, we'll be talking about low cardiac output state. So I am Dr. Avinash, consultant pediatric intensivist and pediatrician from KIMS Cuddles, Kondapur. So in the earlier presentation, we had seen about cardiopulmonary bypass and how it is causing this effect on cardiac output. So we'll have a discussion regarding the further management, okay, of the present condition, low cardiac output state. So in this presentation, we will discuss briefly regarding LCOS. What is the pathophysiology behind that LCOS? What are the contributors and causes of LCOS, and how to prevent and how to identification? That is early identification of LCOS, which is a life-threatening situation, which helps in and the management of LCOS. So coming to the definition, so it is a clinical state where there is an inadequate systemic oxygen delivery to meet the metabolic demands of the patient. So there is a clear-cut mismatch between DO2 and VO2. That is a delivery as well as the metabolic demands, DO2 as well as VO2. So what are the causes? It is frequently caused by myocarditis and those children with the cardiomyopathies and those who are having prolonged brady or tachyarrhythmias, and it is commonly seen after complex cardiac surgeries. So what is LCOS? So it is a syndrome usually occurs after cardiac surgery, typically seen 6 to 18 hours after the cardiac surgery, and it is augmented by the cardiopulmonary bypass. And it is a post-operative phenomenon, and it is most of the time it is a life-threatening, and it requires early identification for the treatment. So it was first reported in 1975 by Parr and et al. It occurs in 25% of the kids post-operatively, and the occurs typically of 6 to 18 hours after the surgeries. So what they observed is like there is a reduction in cardiac index less than 2 liter per minute per meter square. The normal value is around 4 to 5 liter per minute per meter square. So there is a typical reduction of cardiac index, especially 6 to 18 hours post surgery. So before going to the pathophysiology, we'll have a brief discussion about these concepts, which helps in understanding the further slides. So as we all know that DO2 is a product of arterial content of oxygen and cardiac output. So the content of oxygen is dependent upon the oxygen which is bind to the hemoglobin as well as the oxygen which is dissolved in the plasma. So the CaO2 depends upon the saturation as well as the hemoglobin and to a less extent on partial pressure of oxygen, and that is a dissolved oxygen. And in the other way, this cardiac output is dependent upon stroke volume as well as the heart rate. So the cardiac output is nothing but a product of the stroke volume as well as the heart rate. This stroke volume in turn is dependent upon the preload and then afterload as well as the contractility. So the preload is in turn dependent upon this right atrial pressure as well as the left atrial pressure. So this CVP as well as the left atrial pressures are monitored during the post-operative period. And this afterload is completely dependent upon the PVR as well as an SVR. And we will discuss about the other things in the following slides. So as we discussed earlier, there is a supply as well as a demand mismatch during the LCOS, and that is a problem which is caused by the post-cardiopulmonary bypass. So we'll go through the pathophysiology, which was discussed in earlier presentation also. So what happens after cardiopulmonary bypass is like the blood get exposed to the foreign antigen. So because of exposure to the foreign antigen, these pro-inflammatory cytokines as well as the complement pathways will get activated. This leads to the systemic inflammation. So because of triggering of this systemic inflammation, there will be hypermetabolic state. There will be mismatch between DO2 as well as VO2, and then tissue supply as well as the imbalance occur, and this leads to the low cardiac output state. And following cardiopulmonary bypass, there will be myocardial ischemia followed by reperfusion injury, which leads to the cellular and mitochondrial dysfunction and leading to the metabolic uncoupling and energy failure. This in turn causes this myocardial dysfunction. And secondary to the cardiopulmonary bypass, there occurs this pathological alterations in the cardiac loading conditions, leading to the hypovolemia. This hypovolemia occurs because of the bleeding as well as the capillary leak, which is secondary to the CPB. And because of the pulmonary vasoconstriction and pulmonary systemic vasoconstriction, there will be alteration in this loading condition. This pulmonary vasoconstriction occurs because of this endothelial injury as well as a decrease in nitric oxide, and with the ongoing inflammation, and because of the ventilation also. And this systemic vasoconstriction occurs because of this endothelial injury as well as the decrease in nitric oxide, and because of the hypovolemia, which was discussed earlier. This in turn activates this renin-angiotensin mechanism, and this in turn causes this systemic vasoconstriction. So these are the effects of the bypass which will trigger this low cardiac output state. So other operative considerations including this myocardial ischemia as well as a reperfusion injury leading to the rhythm disturbances like AV block as well as junctional ectopic tachycardia, and ventriculotomy leading to the edema as well as the tissue inflammation, which in turn causes this diastolic failure leading to the myocardial dysfunction. See, all this, whatever the mechanism we discuss, all this causes this low cardiac output state. So the regardless of the etiology, the resulting effects are this shock and inadequate organ perfusion leading to the organ dysfunction. So this organ dysfunction coincides post-operatively with the decrease in cardiac index as well as increase in SVR and PVR, leading to the reduction of the cardiac output. So what we have to do is like we have to identify this visual cycle early, and we have to prevent it, and adequate management has to be provided to the child. So as discussed earlier, this the main contributors of this LCOS are the cardiopulmonary bypass, that is the time of cardiopulmonary bypass and inflammatory cascade which is ongoing, and underlying any residual cardiac lesions, and what is that aortic cross clamp time, and any post-operative complications like arrhythmias or any tamponade is going on, or any sepsis is there, or any hypothermic cardiac arrest, or any reperfusion injury is there. So whatever the cause, the anticipation is the key. So how to identify this LCOS? So most of the time we do see like these children will get operated in the morning hours, and by the time the surgery get finished, it will be like late evening, and by late evening or late afternoon, this child will get shifted to the PICU. So once after shifting to the PICU, slowly by midnight, we see that there is an increase in heart rate. So there is a fall in blood pressure, or sometimes there will be normal blood pressure with prolonged CRRT, capillary refilling time, and core peripheral difference of greater than 3 degrees centigrade. So what we call it as like LCOS, which we call it like a midnight nightmare for most of us. We will be like beside the patient while managing this case whole night and all. And those children will be having small area under curve under arterial pulse wave, and there will be increase in lactate levels. There is a worsening of metabolic acidosis, and there will be hypotension, or sometimes there will be normal blood pressure also is possible, and there will be ongoing tachycardia without any kind of arrhythmias and all. So always remember that the assessment of LCOS by clinical examination is often late, and it is like a poor indicator. So we have to identify it early. and we have to provide appropriate treatment for the patient. So the common indices which will be helpful for identification of this LCOS are CVP, right atrial, as well as LA pressure. So LA pressure we will be monitoring through the LA lines. Most of the times, if at all, especially in restrictive physiology and all, they will be these LA lines will be accessible, and sometimes they will be removed in the post intraoperative period, and they will be shifted to the ward. In that time, we will rely completely on the CVP. And we have to see the metabolic acid, whether there is ongoing metabolic acidosis, whether the metabolic acidosis is worsening, how are the lactate level, any worsening of the lactate levels, and serial 2D echoes has to be performed, and mixed venous oxygen saturation and NIRS will be helpful in monitoring of this LCOS. So typically we see that the drop in NIRS value, and this will be helpful in identification of LCOS. So other high-end indices like SVR, PVR, cardiac index, VO2 and DO2, which can be calculated by thermodilution method, will be helpful in identification of this LCOS. And coming to the management, so the main goal of the management is to optimize this DO2 as well as VO2 and establish sufficient cardiac output, and to prevent this organ injury, and to break this visual cycle which we discussed about it in the earlier slides. So always remember that we have to identify this early treatable condition. So avoid this hypothermia as well as an hyperthermia. And if the child is not on mechanical ventilation, intubate, and mechanical ventilation should be continued. And always remember this electrolyte monitoring is very important. And so always remember this electrolyte monitoring is very important. Along with electrolyte monitoring, we have to monitor this extended electrolytes also, and along with this blood glucose, and monitor always these drains, and monitor this volume status, and check for any bleeding as well as ongoing losses and all. So age appropriate targets should be set, and it should be written on the bedside investigate and the bedside papers, and so that children or the doctor who is managing the particular child will be aware of the things. Always try to recognize these arrhythmias earlier, and any hemodynamically significant or non-significant arrhythmias has to be identified early, and it should be treated appropriately, and try to use this syndrome specific inotropes. So coming to the strategies of treatment. So the main strategies includes optimization of the preload, and then augment this contractility, improve this ventricular relaxation, increase the heart rate, and ensure that there is an atrioventricular synchrony. And along with that, decrease in pulmonary vascular resistance and decrease in systemic vascular resistance. These form are the main strategies of this treatment. So along with that, try to reduce the inflammation by administration of the steroids, restore thyroid and adrenal balance, and ensure adequate sedation is given to the patient. And coming to the first step, that is the preload optimization. So how to optimize this preload? So the preload is dependent upon this left atrial as well as the right atrial filling pressures. So always remember this left atrial filling pressure is like 1 to 2 mm of Hg higher than this right atrial filling pressure. So one should know in detail regarding this LA and RA filling pressure when these things are elevated. Suppose in case of PAH and there is an RV dysfunction, only this right atrial filling pressures will be elevated, and those children who is having this LV dysfunction, both right atrial filling pressure as well as left atrial filling pressures will be elevated, and then in case of pericardial effusion also, both LA as well as RA filling pressures will be elevated, and in case of hypovolemia and all, this RA and LA filling pressures will be low. So this CVP is considered as a surrogate when monitoring this right atrial filling pressures. So we'll see a case how we managed this low cardiac output state in our unit. So it's like a 1-month-old child who is operated for TGA with atrial switch repair was done, and he shifted from post-op to the PICU with milrinone. So 6 hours after surgery, what we observed is like his heart rate was slowly started increasing, and there is no ongoing arrhythmias. There is a fall in blood pressure, and in ears started decreasing, and his extremities are cold, and there is no bleeding manifestations. So based on this situation, based on this background, we have to consider the child is in low cardiac output syndrome or low cardiac output state. So how we manage? So how we usually typically manage is like we look at the CVP. So we will see the CVP as a first step whenever the child is having this hypotension and all. And CVP is nothing that the pressure of the heart during the diastole, that is a pressure in the heart which when the heart is relaxing. So as discussed earlier, it is a surrogate of right heart filling. And in LCOS, where there will be diastolic dysfunction and there will be higher CVP, it will the child require higher volume for the ejection of the blood. So what is normal CVP? So most of the time, we in ICU, we are managing the patients without drinking water and all. It will be in like mid single digits, and every heart is different. So the CVP value will be different in each individuals. And especially the children with the top with the restrictive physiology, the CVP will be on the higher side. And those children with the post-operative VSD, most of them will be happy with the CVP of around 9 to 10. So it all depends upon the typical lesions and what kind of correction is done for the patient. So what we do is like, first step is like we look at the CVP. So we look at the CVP. So if the CVP is less than 8, so we'll start administering the fluid for the child. So first initially we'll give the bolus of around 5 ml per kg, and we'll see the heart rate as well as the BP. If the heart rate is coming down and if the BP is improving, then we'll see the response and we'll accept, and we'll see the CVP whether it is increasing or not. If there is no change or there is a drop in blood pressure after administrating of the fluid, we'll stop the fluid, and we'll go with the next step, that is administration of this inotropes and all. So always remember not to push too much of fluid, or too rapid push should be avoided in these kind of children. So what kind of fluid has to be given is like there is no consensus regarding it. So it all depends upon the unit protocol, and whichever we are comfortable, we can consider giving to the patient based on these electrolyte levels and all. So for our patient, we gave the fluid and CVP got elevated. CVP was elevated till it reached around 10 to 11, and still the BP is low. So what next? So, next thing what we have to address is the contractility. So how we address this contractility? So usually if you see this mild dysfunction is quite common after cardiopulmonary bypass. So moderate to severe dysfunction causes this low cardiac output state, and it should be evaluated by the serial echoes. So always ensure that the calcium and magnesium is ongoing, and inotropes will be helpful to deal with this myocardial dysfunction. So in such kind of scenarios, the first step, first line agent, what we use is epinephrine. So depending upon the situation, like whether the blood pressure is lower or blood pressure is the normal, we can consider using of a low dose as well as a high dose epinephrine. So low dose epinephrine consider as like an inodilator, and high dose epinephrine we can use it like an inoconstrictor. So in this child, we started adrenaline on 0.1 microgram per kg per minute. So, and after starting of adrenaline, the blood pressure got stabilized. So after 8 hours after starting adrenaline, the child became tachycardic. There was a poor capillary refilling time. The child started having these cool extremities and low NIRS, but blood pressure was normal. So if we see this kind of scenario, so we can see that even after starting this adrenaline, the child started having tachycardia, and there is a poor CFT, cooled extremities and all. So we are dealing with a condition like where there is a low cardiac output state with a normal blood pressure. So we have to consider this syndrome specific inotropes. So here what we started is like a milrinone. So after starting milrinone, which is like an inodilator, it helps in contraction as well as it helps in dilatation of the blood vessels, which helps in supply of blood to the peripheral tissues. And this problem of poor CFT as well as cool extremities can be taken care after starting with the milrinone. So this child was started on milrinone infusion at 0.5 microgram per kg per minute, and was continued on low dose adrenaline of 0.05 microgram per kg per minute, as low dose adrenaline will be helpful as an inodilator also. So the choice of inotropes. So the choice of inotropes is very important while managing the post-operative child. So different scenarios we mentioned here. So those children with low cardiac output, that is a low ejection fraction and high SVR, one can consider using this inodilators, that is a low dose of epinephrine as well as an milrinone. And those children with high cardiac output and low SVR, one can consider using this vasoconstrictors like a norepinephrine as well as an vasopressin. And those children with low cardiac output and low SVR, we can consider inoconstrictor, that is a dose of adrenaline at a dose of greater than 0.05 microgram per kg per minute. And those children with high cardiac output and high SVR, one can consider using these vasodilators like NTG, nitroprusside and pentolamine. So as we discussed here, so we optimized the cardiac output by increasing this preload. So by increasing this contractility, now we'll address this heart rate. So how this heart rate will be helpful is like we'll see in the next slide. So this was a child currently in our unit. So how we manage by increasing this heart rate. So yeah. So if we see here this vitals, the child is having the heart rate of around 141. If you closely observe this ECG rhythm, so here there are no P waves, okay, and where you can see that Canon A waves are present, okay, and the blood pressure is around 92 by 57. So the child is in junctional ectopic tachycardia. So what we did is, so we started overdrive pacing for this child with a heart rate of around 150, and we will see that what's happening with the blood pressure in this child as well as the CVP. Try to observe this blood pressure as well as the CVP. So here we are pacing with an heart rate pacing around 150, and one can see this improvement in the heart rate. Previously, improvement in the blood pressure. Previously, it was around 93 systolic. Now we can see this systolic of around 106. And look at the CVPs, how it became normalized. Previously, there was an Canon A waves. Here there is a normalization of this CVP waveforms and all. So this is how this optimization of the heart rate will improve. So one has to target this optimization of the heart rate. So the increase in heart rate will be helpful to some extent. So if we keep on increasing this heart rate till 180, 190, so what it happens is like it increases the myocardial oxygen demand. So there will be like a poor diastolic flow, poor diastolic flow, and there will be the coronary perfusion will be reduced, and there it causes in turn causes this myocardial ischemia, and this will causes myocardial ischemia and further damages the heart. So one has to be very careful while increasing this heart rate and all. So here in this patient, we took care of this preload, we took care of this contractility, and we took care of this heart rate. Even after doing everything, this blood pressure was on the lower side. So now we are taking care of this ventricular afterload. So what problems we deal with afterload is like afterload mismatch. See, this afterload mismatch usually occurs in those patients with in a post-operative repair of VSD as well as a PDA, and those children who had undergone the repair of a mitral stenosis or regurgitation. So there will be like a relative afterload mismatch will be there. So such a condition has to be dealt, and afterload reducing agents has to be administered to the patient. So this reduction LV afterload will improve this cardiac output as long as an adequate diastolic pressure is maintained for the coronary perfusion. So these are the agents which we use for reduction of this afterload. One is for reduction of this left ventricular afterload, one can consider using this milrinone, low-dose epinephrine, dobutamine, pentolamine, and sodium nitroprusside. And when even the ventilation also causes, mechanical ventilation also helps in decreasing this afterload of the left ventricle. So for decrease in right ventricular afterload, which was discussed in earlier presentation in the PH crisis and management of PH, so one can consider using this milrinone and hell nitric oxide and sildenafil and prostacyclines. So these are the various afterload reducing agents which we use in the post-operative period. So most commonly used are milrinone and low-dose epinephrine, and other agents like NTG and pentolamine, depending upon the cardiac lesions and depending upon the surgery, we consider using them. And most of the time, the physiological positive pressure ventilation will help in reduction of this LV afterload, and other agents like captopril and enalapril. And during the weaning time, we will consider using this afterload reducing agent. So coming to the RV afterload, which was discussed in the earlier presentation. So I won't go much in detail regarding this RV afterload. It was discussed earlier. So now what happened is like we took care of this preload, we took care of this afterload, we took care of this contractility, and we optimized this heart rate. So even after doing everything, even the still the child is in hypotension. So what you have to do is like next step is like look at the chest tube. So what's happening with the chest tube? When any ongoing bleeding is continuous, very drains are like continuous, with that is causing hypovolemia for the child. You have to monitor in that, and also look for any blockage of the chest tubes. So blockage of the chest tubes leading to the tamponade effect also you have to rule out. So always if the child is not improving under, always order for a 2D echo, and then look out for any residual heart lesions and looks for any coronary perfusions and all. So, and if there is no other improvement and all, one can consider using this post-operative steroids if the shock is refractory to fluids as well as vasoactive medications and all. So usually post cardiopulmonary bypass, there is an with an ongoing inflammation. So this LCOS is using the steroids, especially the hydrocortisone. So the management includes fluids, vasoactive medications, as well as plus or minus steroids. They form the backbone of management of LCOS. So this is a typical algorithmatic approach of LCOS. So as discussed earlier, take care of other things like avoid hypothermia as well as an hyperthermia, and strict monitoring of this blood sugar, monitor the blood, monitor the drains, and rule out any tamponade effect. After that, optimize the preload by giving the fluid challenge of around 5 to 10 ml per kg, and look at the CVP, what's happening with the CVP, whether there is an increase in heart rate or whether there is a decrease in heart rate happening, what's happening with the blood pressure, you have to see. So once after optimization of preload, one has to take care of this myocardial dysfunction by using these inotropes and all. So depending upon the syndrome, we have to consider what kind of inotropes has to be used in this patient. So once after this optimization of this preload as well as taking care of this contractility, one, if it is possible, try to augment this heart rate and try to take care of this try to take care of this afterload. And then if the child is refractory to all these things, one has to consider about this mechanical support by taking the child on ECMO and all. So these things already we discussed, that one has to take care of this electrolyte sedation as well as infection control as well as glucose hemostasis and all. So if the child is not improving and in the later stage, one has to consider this mechanical cardiac support and all by taking care of this LVAD as well as an ECMO. So thank you all.
Thank you. Sorry for delay.
Yeah.
So good evening to all. Okay. Myself is Lingaswamy, pediatric cardiologist, KIMS Sunshine Hospital, Begumpet branch. So the topic is today for discussion is challenges in the management of various palliative shunts especially in the post-operative CHD. So before going to that one, I will go to the what are the type of palliative shunts generally we will do routinely in the post-operative phase. Okay. Yeah. Traditionally, congenital heart diseases are divided into the two groups. One is cyanotic group, one is a acyanotic group. It's depend upon based on visibility of cyanosis. So in the cyanotic group also, there are some categories are there, like decreased pulmonary blood flow group, increased pulmonary blood flow group, admixture physiology, transposition physiology. Accordingly, sector of the congenital heart disease will come under these categories. So this is the traditional classification. You can see here, this is the 2.5 month child having the respiratory distress. So having the congenital heart disease, that is a truncus arteriosus, baby is showing the saturation of 87%. So X-ray showing the cardiomegaly, obviously you are seeing increased vascularity. But there is no visibility of cyanosis. But traditionally classification showing that you have to see the cyanosis, then only you can classify it as a acyanotic and cyanotic. But here this child having the truncus arteriosus. So where we have to put these type of congenital heart disease? That is the dilemma. So there is the traditional classification old like cyanosis, visible cyanosis, then only we have to classify into cyanotic and acyanotic. So now it's the time to replace the terminology from cyanosis to arterial desaturation. Means that you can't able to see the cyanosis. So appearance of cyanosis to come, it has to be saturation to be less than 85%. So this child is not having a visible cyanosis, but the saturations are low. So basically, how we can classify in a cyanotic congenital heart disease as a congenital heart disease with arterial desaturation, traditionally called as cyanotic congenital heart disease. So how you can classify a cyanotic congenital heart disease with a normal arterial saturation? So that's why we have to divide it into two groups of now the replacing the classification of old terminology of congenital heart disease with arterial desaturation and normal arterial saturation. I hope that you people understand that now we have to change the terminology of cyanosis to arterial desaturation. How you treat a various type of congenital heart diseases. Basically, I will restrict our topic to palliative shunts. So I will come to mainly to the cyanotic group. So basically, we have to decide into is it possible to suit biventricular correction or single ventricular correction. So if a biventricular correction, for example, TGA intact ventricular septum, TAPVC, it's a single stage biventricular correction possible. So completely we can do single stage operation. For example, sometimes in the single ventricle conditions, tricuspid atresia is there, single heterotaxis syndromes are there. So some type of the tetralogy, VSD, PS physiology conditions, not possible to do repair single stage correction. We have to do staged correction in this condition. Staged correction means initially we have to undergo one type of surgery, which is act as a palliative. Then we have to subject the child again for further assessment. So is it possible for biventricular correction? If not possible, we have to make the child further palliative procedures to single ventricle. So what is the use of any palliation? Palliation use is make the baby relieving from cyanosis. That is the very first important step, and make the baby to growth. It's a physical growth and all the things are, and also prepare the phase for next stage of surgery. If you repair the stage of one surgery, then it will be make the baby to growth for next stage of surgery. So what are the generally will do the commonly we are doing the palliative shunts. We all know that one. This is the heart of the tetralogy fallet. You can see in this one, this is the right side, this is the left side, large conoventricular VSD and pulmonary stenosis is there. So generally classical BT shunt generally previously they are doing it. What is the meaning of classical BT shunt? Rerouting of the right subclavian artery to pulmonary artery. Because of this, whatever the oxygenated and deoxygenated blood from the aorta is coming back into the pulmonary artery, it is circulating. So what is the disadvantage of because of this classical BT shunt? It's affect the limb ischemic problems. So growth abnormal, all this will happen. To overcome this one, they made that a modified BT shunt. What is the modified BT shunt? They put the material, tube-like material that is called Gore-Tex material. So with that, they connect the subclavian artery to pulmonary artery. If the side of the subclavian, means side of the arch of aorta will decide which side we have to put, because length of the subclavian artery will needed for to put the adequately to sutured at the end of the subclavian artery side. So length and diameter of the graft will decide that is the child is subjecting to over circulation or under circulation. This is the one more type of the modified BT shunt, another type of palliative shunt. And the next shunt is the water shunt and pot shunt. These are the central shunts. Why these center shunt? Because entirely directing the blood flow to the either side of the pulmonary artery. So if you child undergone these type of thing, mainly unilateral pulmonary over circulation will happen. So after this, they only perfuse to only one lung. So pulmonary edema, all the things will be happen. So to overcome this one, there is another type of palliative shunt is came. What is that one is? That is called Cyanosis shunt. What is the Cyanosis shunt? Here is the right ventricle. So here is connected a tube-like material, like conduit, connecting directly to the pulmonary artery. So this is a like conduit connecting from right ventricle to the pulmonary artery. It's like a native RVOT. How the ventricle will contract blood flow into the pulmonary artery, it will go into the branch pulmonary artery. Similarly, the contraction of the ventricle will induce the blood flow to the pulmonary artery. This is a native physiological blood flow pattern of system. So next is the palliation is called central shunt. What is the central shunt? So here, especially in the tetralogy fallet with pulmonary atresia MAPCA dependent circulation, we dissect the pulmonary artery from the RV, then we re-implanted into the ascending aorta. Whenever we re-implanted, the blood flow is equally distributed into the right pulmonary artery and the left pulmonary artery. It makes the patient for preparing for the next stage of surgery. If the branch pulmonary arteries are small, central shunt will be more benefit. So this is the commonly we will do the aorta pulmonary shunt. Generally in the most probably we are doing in the neonatal age group to infantile phase. So what is the next modality of palliative shunt is the bidirectional Glenn shunt. What is the Glenn shunt? Glenn, you can see here, this is called as a classical Glenn shunt. What is the meaning of classical BT shunt? Like classical BT shunt, there is a classical Glenn shunt also there. So what is mean? We divided the SVC from the right atrium and connected the pulmonary artery. So only in the classical BT shunt, MPA also division from the RPI division from the left pulmonary artery. So only the blood flow is going to the single lung. Other lung is not maintaining any circulatory phase. So whatever the native flow is coming and it's coming. So whatever the predominantly it's coming through the left side, the right side. So what will happen over a period of time? So it's not good. So only single lung is only working. So what they maintain, they not disconnected the right pulmonary artery from the left pulmonary artery. So the SVC blood is direction to the both right pulmonary artery and left pulmonary artery. So this is called Glenn shunt with it's circulating into both and RPA and LPA. This is called bidirectional Glenn shunt. So you can see here, this is the case of tricuspid atresia. You can see this here is a tricuspid atresia. RV is very small. Right atrial blood is circulating to the left atrium. You can see here this child underwent the Glenn shunt. Superior vena cava blood is circulating to the right and left pulmonary arteries. So next modality of palliative shunt is the Fontan or total cavo-pulmonary anastomosis connections. What is the meaning of total cavo-pulmonary connection? So already in the Glenn shunt, we connected the SVC to pulmonary artery. Then IVC, we have to connect it to the pulmonary artery. That is called total caval pulmonary venous system is connected to total caval veins are connected to the pulmonary veins. So there is a one type of fontan is called lateral tunnel fontan. Another thing is the extracardiac fontan. Previously, what they are doing, so they made the tunnel inside the atria with the use of the Gore-Tex or pericardial patch. They made a tunnel and make rerouting the IVC blood into the pulmonary artery. This is called lateral tunnel fontan. So over a period of time, what happened because of the inside the atria, there is arrhythmia chances and also the fontan failure happening. So they made that tube-like material. This is called conduit. This is extracardiac fontan. It's not at all involving the atrias in this phase of any of the circulation. So this is called extracardiac fontan. Generally, nowadays we are replacing the almost like whatever the lateral tunnel fontan with the extracardiac fontan. So let's go to the today topic. What are the challenges generally we'll see in the post-op palliative shunts? So I discussed already is the aorta pulmonary shunt or BT shunt. So basically, BT shunt, normally the circulation is series phase of circulation. BT shunt makes that circulation into the parallel circulation. And blood flow is a high velocity pulsatile blood flow because aortic pressures are so high compared to pulmonary artery. So the velocity, each contraction, like how is the left ventricle will contract and produce the systolic and diastolic pattern of blood. Similarly, like that BT shunt also produce high velocity pulsatile blood flow pattern. And I told you the circulation is like parallel circulation. It means that whenever the circulation is parallel, pulmonary artery saturations are equal to systemic artery saturation. So BT shunt makes the increase the pulmonary blood flow. So I told you it reduce the cyanosis, increase the pulmonary artery growth. I will explain you cardiac preload, how it will be preserve all the things. Before going to explain all the things of what are the challenges, we have to know about the what is the QP by QS. In the normal circulation, we will get the saturation of 100% whenever the QP by QS is equal to 1. What will happen if the saturation in a BT shunt lesion and a single ventricle physiology condition, our targetable saturation is 80 to 85%. With this saturation itself also, QP by QS is 2:1. How it's happening? Let's see. So how we will calculate QP by QS? Basically, QP by QS, how we can calculate aortic saturation divided by pulmonary vein saturation minus systemic vein saturation divided by pulmonary artery saturation. So we all know that one. I taken the example that if the child maintaining the saturation of 80%. So I taken the aortic saturation as 80%, pulmonary vein saturation as 100%. I assumed, because pulmonary veins are 100%. So normally systemic vein like SVC saturation are 60%. So I already explained that aortic saturations are equal to pulmonary artery saturation. So whenever you calculate this one, QP by QS will come is 1:1. It means that 80% saturation means QP by QS is 1. So when you take that one, saturation is maintaining 90%. How much is the QP by QS? QP by QS is 3:1. Our target is QP by QS has to be 1, and also it has to be maintained the saturation of 80%. That is the main target whenever in the BT shunt cases. So what is the indication of? Here I told you oxygen saturation means is indirectly telling that how much amount of blood flow is circulating to the lungs. So what I want to tell you here, it's not is the how much is the lungs are working. Oxygen saturation, for example, 80% saturation is it's a balanced circulation. Pulmonary blood flow is balanced. If the saturation is 90% means overflow, means pulmonary blood flow is increased. So oxygen saturation indirectly telling that pulmonary blood flow especially in the BT shunt cases. So whenever the patient with the BT shunt received from the OT, what are the checklist points you have to get from the OT? So one thing is age of the patient, because prematurity will make the other complicated issues, make the complication the issue. Syndromic association is there now. Underlying cardiac condition, because pulmonary atresia, intact ventricular septum, and Epstein anomaly condition, single ventricle, these having the other than that BT shunt complication, there are other unexplained things will be happen, especially in these cases. So that's why very high risk of mortality explained in these cases. Pre-op sepsis, mechanical ventilation, and is there any thoracotomy and sternotomy, either PA plasty, other than that BT shunt, any other atrial septectomy or branch pulmonary arteries are repaired or not, is done under the cardiopulmonary bypass or not, and size and length of the graft of the whatever the BT shunt we kept. Is there any other than BT shunt, any other flows like MAPCAs are there, PDS is there or not? We have to go through all the checklist, and how much dose of heparin whenever you received, how much is the APTT, all the checklist points we have to get whenever we received any patient from the clinic. Then how you can proceed that patient? One thing is our aim of target is saturation is 75 to 80%, because we have to maintain the QP by QS of 81. So always auscultate any patient with the central shunt. Always there is a murmur. That is the simplest, easiest clue is the BT shunt is working or not. The way one simple thing is, how is the saturation? Is there any murmur? Is there or not? So if the murmur is loud and also you are hearing both systolic and diastolic component, you are saturating 80%, then nothing is needed. You get the BT shunt is working very nicely, not need of any echo for that patient. And always check the diastolic blood pressure, because if the diastolic pressure is less than 25 is there or 20 is there, you have to be think that there is already pulmonary over circulation is going on. And other things are drains, bleeding. Is there any inotropic support is going on? Echocardiography wise, ventricular function, is how is the shunt status? Fluids always start with the 80% maintenance, especially because BT shunt is a parallel circulation. It means that it will add on increase the volume overload to the ventricle. So it's like ventricle volume compared to normal circulatory phase, the volume will be further overloading of happen. Maintain the hemoglobin 12 grams is mandatory, because under circulation means if you not maintain that, there is polycythemia is there, there is a shunt block is very high chances are there. Start heparin 10 units per kg after checking of the baseline APTT of the thing. So let's go to the, is the patient is overflowing. So what are the basic things we will get without echocardiography? I want to tell you. So SpO2, if the saturation more than 90%, 85 to 90%, chest X-ray showing the congested lung signs, and also the crepitations are there. ABGY showing the elevated lactates and metabolic acidosis. So because of systemic underperfusion happening, diastolic pressures are less than 20 is there. And if ECG wise any ischemic changes are you are seeing, then you all think that there is a overflow state is happening. So how you can manage? The problem here is happening is PVR is very, very low and SVR is very high. That's why it's a overflow is happening. So what we can do here, one thing is our aim is to increase the PVR and reduce the systemic vascular resistance. But the problem here is there is not much medications to increase the PVR. Then how you can decrease the or increase the SVR? So our aim is mainly with the mechanical ventilation. Try to reduce the FiO2 to less than 21% and maintain the pH. Avoid the hyperventilation. Okay, and PPs you have to maintain the 6 to 8. You have to make the lungs to be dry. And the same thing is reduce the SVR. How we can reduce the SVR? Start diuretics and fluid restriction and start the vasodilators as much as possible. Make the SVR has to be come down. So if the diastolic pressures are very low, you start the noradrenaline because what is the beauty of noradrenaline is noradrenaline increase the systolic blood pressure, diastolic blood pressure, mean blood pressure. That's why diastolic blood pressure, if you want to maintain, the noradrenaline is the best option, especially in the case of BT shunt cases. If the still saturation, sir, you are managing all the things, sir, but still very high saturation, you have to suspect that is there any PDA or any other associated collaterals are supplying the increased blood flow, especially in these cases. So next thing is, whenever obviously increased blood flow, high saturation means there is oppositely low saturations also you will expect in the post-operative phase. So if you low saturation less than 70% means what are the commonly? Definitely there is a decreased pulmonary blood flow. First thing is you have to think a bit shunt blockage or thrombosis is there. And then second thing is any systemic hypotension. If there is a PVR high, branch pulmonary arteries are very small. You put the stent is very small and any lung issues are there. And if operated in neonates, there is a high PVR is there or not. We have to think about all the possibility causes. So obviously shunt blockage, I told you, saturations we have to see. Second thing is respiratory cause of desaturation is there or not. And ABG wise, clinically there is a no shunt murmur. That will be give lot of clues in that, especially in the shunt blockage. So always the management very important, especially in the shunt blockage, because they will not give much time compared to over circulatory shunt. Always think that whenever low saturation, you think that is a shunt block. You have to act very quickly and also try to do urgent echo if possible and inform the surgeon and cardiologist as early as possible. So try to give the fluid bolus. If there is a systemic hypotension causing the low saturation, try to give more than 5, 10, up to 10 is acceptable, because if the systemic hypotension causing the shunt block, if there is a more than 20 to 30 ml, if need of patient is needing 20 to 30 ml per case, then you have to think about there is not only hypotension, there is a shunt block or thrombosis, something is happening that causing there is a decreased pulmonary blood flow. Here our aim of thing is reducing the PVR and increase the SVR. That is the one thing. So obviously you can give the mainly with the 100% FiO2, hand ventilate, maintain the alkalosis, and reduce the SVR, always give the fluid bolus, and also they start adrenaline, noradrenaline, anticoagulation. Try to give, after doing all the things, straight away give the bolus and start the maintenance. Especially in neonates, you can start the PZ even. If you have ruled out the almost like any no pulmonary arteries are adequate, no thrombus, nothing is there, then you start the stent flows by echo is good. Start the sildenafil, because especially in neonates, PVR is very high for these cases. If still low SpO2, you are not able to gain the good amount of saturation, pulmonary blood flow is not improved, then you have to go for the tissue, means alteplase. This is the one recombinant tissue plasminogen activator, because short acting, and also this can be, we can do it. You can see here, this is the one we injected in the right subclavian artery. The proximal portion of the BT shunt is occluded. What we done is, we opened with the balloon, then re-shunted that one. You can see this one, post-procedure, the blood flow to the BT shunt is good and pulmonary artery is filling nicely. So you can see here in the second picture, the subclavian, here is the BT shunt is some form of filling defects is there. LP is not even filling anything. So we given the tissue plasminogen activator here. So the defects are, means like the opacity is somewhat better and LP is filling now. So tissue plasminogen activator, TPS, or we can give by directly catheter director or by giving of IV also, it's benefit in these cases. So I told you second level of shunt is the shallow shunt. So this is the one is conduit based, because RV is the contractility causing the blood flow to the pulmonary artery. This is called shallow shunt. The main advantage is here is not at all matters about the how much is the systemic blood flow, how much is the overflow. Here it will not maintain anything problem with the QPQS. The main disadvantage is In a small babies, because its a size is very small, you have to be upgrade very frequently, because hypoxia, what we can get in the BT shunt, in a Shano shunt is very early in the Shano shunt phase, and this, but QPQS we can maintain very nicely these type of Shano shunt cases. The next shunt lesion is Glenn shunt. I will explain very shortly this one, why we have to go for Glenn followed by Fontan. Why not directly we can go for Fontan, all the patients. So I will explain this. This is the, if you take as a 100% normal circulation, how is the ventricle? Ventricle is normal throughout their lifetime. What will happen if you, for example, single ventricle patient, if underwent the shunt lesion? So because of parallel circulation, volume of the ventricle will be increased. So after some period of time, already ventricular volume is increased to 50% more than the baseline. If your baseline is 100%, the ventricular volume after the doing of shunt, it become 150%. So over a period of time, what will happen? The shunt will not become small. Child is growing. So shunt volume of the ventricle, because the shunt is working very low level. So volume of ventricle is come down. Again, if you do undergo again one more shunt, then again same thing happening. If the patient is undergone the Fontan, suddenly Fontan means it's a volume is preload is reducing. That is the concept of Fontan. If you suddenly volume overload ventricle become the ventricular volume become negative state, means like minus 50% of the previous value. Sudden volumetric changes will cause the so much of diastolic dysfunction. These type of cases will not be behave very nicely in the post-operative phase. Fontan failure is very high chances if you frequently undergone the Glenn this is the one BT shunt in the subsequent phases. So if your patient is not undergone any shunt lesion, directly that patient, because it's escaped from the shunt phase, then it's underwent directly the Glenn shunt. What will happen? The ventricular volume will come down like around 30%. If the Fontan means, it's again will come down to again 30%. The ventricular hemodynamics will be maintained. Means that how, means the diastolic function will maintain these type of. So always try to go with the staged wise manner. Then compared to directly, we can go for BT shunt with the Fontan. So always the recommended methodology nowadays is the Glenn followed by the Fontan. This is the thing. So I already explained to you, this is the, how the Glenn physiology is working. The blood flow is coming from the SVC to both pulmonary arteries, right and left pulmonary arteries. So this is called bilateral Glenn shunt. So how it will be affecting the bilateral Glenn shunt? So what is make the BT shunt will be, here the circulation make the series type of circulation. What is the meaning of series circulation? So whenever the circulation become, for example, in a normal circulation, how is the circulation? I will explain you next few slides. Here I will go to further. So blood flow here in the depend upon the how much is the pulmonary vascular resistance is less. That is the main important thing in the Glenn shunt. So if the PVR is very low, then the circulation will be very good. So it's a depend upon mainly on the intrathoracic pressure. Generally, ideally, age for Glenn shunt is more than 3 months of it. Why we have to go for after 3 months? Because neonatal PVR is very high. It's a passive phase of circulation. So it's a vena cava pressures are very low. If you face that one, a PVR is, if for example in neonatal phase PVR is very high, the Glenn will not be work. So always try to do after 3 months of age group. So how you can monitor? So Glenn pressure post procedure, you have to check that one, and also check the LA pressures. How you can check the LA pressure? Definitely, if your patient is undergone the Glenn shunt, definitely there is a ASD is there. ASD will be large. RA pressures, LA pressures are equal to CVP. Always measure the difference between the Glenn pressure and the femoral venous pressure. So try to avoid the air bubbles, and also they try to remove once the patient is received from the OT central venous line, because high risk of thrombosis these cases in things. So it's a extra cardiac shunt, obviously minimal support. You have to maintain the difference between the pulmonary venous, means PA pressure minus LA pressure, the difference has to be less than 5. So this is called as a transpulmonary gradient. This will dictate that how much amount of the blood flow is circulating. So obviously you have to start the anticoagulation. So pain relieving agents. So I want to explain that one. Here is the ventilatory strategies are very important in the Glenn shunt. So why? Because try to extubate early. So spontaneous breathing means negative intrathoracic pressure make the SVC blood will be further increased, then PVR will be automatically will come down. There will be the more amount of blood flow going to the lungs. So when you continue the ventilation long period of time, there will be the the saturation will be always will be the low. Try to be extubate as early as possible. If you want to need of child, definitely need of ventilation is a small age group. Always use the PRVC control mode, low the inspiratory pressures, and also the PP has to be low. And there is a concept called as a permissive hypercapnia will come especially in the Glenn patients. So what is the meaning of permissive capnia? I will tell you here. Here, this is the 14 patients undergone the Glenn surgery. So this is the baseline. They maintain the PCO2 of 42 and bicarbonate of 25. And some patients, around 4 patients, 5 patients, what they done is they given the bicarbonate infusion. Then after what they make the PCO2 make to 45. And some of the patients, they made the hypoventilation. They made the PCO2 is very high level, 58. So what is the, after get this 3 studies, what they done is, what is happening generally, the PCO2 effect means that CO2 effect on the lungs is different from the cerebral circulation. Whenever the PCO2 is high, what is happening? The lungs, it will happen pulmonary vasoconstriction. Similarly, not in the similar phase, PCO2 will causing the cerebral vasodilation. Whenever the cerebral vasodilation is there, return from the SVC is more. So that's why they started increasing the permissive hypercapnia. So PCO2 maintaining higher level, 45 to 55. Why they maintain? So if you get the doubt that during that high PCO2 level, there is a chance of pulmonary vasoconstriction. So here they studied that pulmonary vasoconstriction is not that much if you maintain the PCO2 of 55 level. Up to 55 level, there is not much change in the pulmonary artery pressure. So they introduced the concept called permissive hypercapnia, maintain the PCO2 of 45 to 50 higher level than normally we can do for routine cases. So with this way, pulmonary blood flow will be increased. The next thing is the Fontan physiology. In this Fontan physiology, I already explained you the conduit we can redirect the blood from the IVC blood to the SVC. Here is the 3 important things. One thing is pulmonary blood flow is not even at all with the ventricle. Ventricle is not at all pumping the. Generally, how the pulmonary blood flow will go with the ventricular contraction, blood flow going to the lungs. But here, it's independent of pulmonary ventricle. Here is the 3 important things. One is the difference between the pulmonary artery pressures and LA pressure. This gradient will be determined when how much amount of blood flow is circulating into the maintaining the cardiac output. And the second important thing is how much is the suctioning force of the ventricle. It means the diastolic function. So that's why as age increases, diastolic function will be worsened. So most of the cases after 40 years of age group, there is a chance of that Fontan failure. It's not because of, it's like circulatory problem. It's because of suctioning problem, because the LV compliance will be decreased. Whenever the LV stiffness will be increased, then there will be automatically the Fontan failure. Fontan failure means it's not a systolic failure, it's not a diastolic failure. The pressure difference between here to here will be reduced. Whenever the difference will be high, the blood flow will be good. But here the Fontan. So what is the here you are seeing the any Fontan physiology? If you go to read, this will be gross will come. I will try to explain very shortly. You can see this one LV. So LV blade is coming to aorta circulating to systemic circulation. Then it will come to the right ventricle, right atrium, then pulmonary artery. This is the one normal circulatory phase. This is called as a series type of circulation. Means that there is no extra connection communicating directly. So what will happen whenever the shunt lesion happening? This is the ventricle. From the ventricle, aorta is coming. Okay, we all know that one. Aorta is supplying the both pulmonary artery and the through the BT shunt, and this is the systemic circulation. From the systemic circulation, venous phase. From the pulmonary circulation, lungs, it's circulating again back to the atria to ventricle. So you can see that one, the thickness of this graph, the ventricular volume will be increased because same, it's not like a oxygenated blood is coming to lungs, deoxygenated blood coming to the lungs, then purification, then circulating. But here, there is a like too much of like effective blood flow is not there. Blood flow is going on, but effective blood flow is not there. So obviously QP will be increased here. So same thing, we are coming, BT shunt means it's a parallel circulation. We are making series to parallel to again to series. In the fountain, what is happening? You can see here in the fountain, the ventricle, aorta, from aorta, what is happening? IVC or SVC. From the IVC, SVC to blood is going to pulmonary artery to pulmonary vein to LA. So this is the thing. So there is no extra connection like parallel circulation. It's making to series circulation. The problem, the pressure gradient between the systemic veins to LA, the difference between this one to this one may determine the cardiac output. This is called as a transpulmonary gradient. When you maintain the transpulmonary gradient of more than 5, then you feel that it's like cardiac output is adequately maintaining. So what are the goals whenever you see in the fountain circulation? You have to maintain the CVP little bit high. TPG is transpulmonary gradient 5, and also the hemoglobin, maintain negative thoracic pressure, preserve the function of diastolic function of the ventricle, and also the sinus rhythm is very important. Why I want to tell you is the sinus rhythm, because diastolic function, there is a two components. Passive phase is there, atrial contraction. So atrial contraction will contribute the significant cardiac output in case of fountain phase. That's why AV synchrony and sinus rhythm is very, very important whenever you are doing this one. And ABVR, and also try to reduce the PVR, all the things. So what are the common challenges we will see in the post-operative phase? Obviously, one thing is low saturation. So pleural effusion in the glen, especially hypertension, and also SVC syndrome. Face is so much swollen, child is so much irritable, and also similarly in the fountain also, because total cavopulmonary. So I will explain both together. Very few slides are there, so I will go very fast. So whenever you see the low saturations are low, always think that is there any pulmonary vein desaturation. First important thing is, especially in the glen patient, is the pulmonary vein desaturation. You take the X-ray, then is there any effusion, is there pneumothorax, is there pneumonia, all the things try to rule out. If there is a systemic vein desaturation, try to, is there anemia? How is the oxygen consumption? Is there any sepsis is there? Then decreased pulmonary blood flow. If the blood flow is low, then you have to think about, is there any intracardiac problem or any pathway in the obstruction in the pathway? You have to rule out all the things. I will explain very simply here. So all other things, you have to think about any desaturation mean veno-venous collaterals. What is the veno-venous collateral? From the systemic vein to pulmonary vein, if there is a directly desaturated blood is circulating into the pulmonary vein, then you think that this will causing the desaturation. And second thing is, how is the fenestration? If in the fountain phase, if the fenestration is very large, it will cause the desaturation. And second thing is, how much is the antegrade flows? So from pulmonary artery, if there is some residual flow, it will increase the pulmonary artery pressure. I told you arrhythmias also you have to be considered, and atrial arrhythmias, AV synchrony, pacing is you have to be maintaining these cases. So especially in the glen patient. So immediately after the glen, there is obviously there is systemic hypertension and bradycardia. What is the reason for these things? One thing is obviously the pain. Second thing is the suddenly if you expose the cerebral venous system to high pressure pulmonary artery, what will happen? Cerebral raised intracranial pressure. So to compensate for that one, raised intracranial pressure will cause this bradycardia and hypertension. And second thing is as this catacholamic surge, acute reduction of ventricle in the glen will cause the hypertension and bradycardia. Don't at all treat this type of hypertension aggressively, because it's a cerebral circulation dependent, causing the like raised ICD, maintain the cerebral perfusion. Because of that reason, in the hypertension is coming. So next is the high PVR is there. Always check the PV. How much is the SVC pressure? If the SVC pressure more than 14, is there any obstruction or thrombosis? High PVR is there. And second thing is post-operatively, post-glen, the child is very so much irritable after next 2 to 3 days, because suddenly a customization is not possible, especially cerebral circulation, raised ICT. So you can give diuretics or mannitol, these type of cases. And the last thing is the cardiac output. So I told you fountain failure means it's not a systolic failure, it's not a diastolic failure. The problem is in the either in the pathway of this one, either from the SVC or pulmonary artery, either in the left atrium or diastolic dysfunction. So how you can identify these things? How first thing is how is the CVP? How is the central venous pressure and the LA pressure? If the difference is more than 7 is there, and the child is desaturating, always think that there is a decreased blood flow. If the normal arterial saturation is there, LA pressure surflow, then you have think that there is a fontan fenestration. You feel that saturations are good. It means that this is not at all normal, because fontan failure means CBP high, means there will be the systemic venous congestion will happen. So whenever systemic congestion, acute liver failure, and also other cerebral congestion symptoms will cause the problem. So it's not at all saturation maintenance is not at all normal in the. You have to maintain the CBP as much as possible, 12 to 14. If not maintain more than 14 or 18, this will cause the fontan failure. And also if the both are low, you have to think that there will be the hypovolemia. If the CBP high, LA pressure is also, always think that there is an intracardiac problem, means ventricular dysfunction, arrhythmias, all the things. So same things I told you. So if there is a persistent pleural effusion and chylothorax, generally we'll see post-fontan and post-Glenn. The problem here is the one thing is suddenly systemic venous pressure. So where is the lymphatic channels are draining into the SVC. So there is a highest level of systemic venous pressure is the lymphatic accumulation happen. There will be the systemic venous congestion causing the leakage of the lymph into the pleural and pericardial. Is there any elevated PA pressures and thrombotic problem is there, and our other lymphatic problems are there. So we all know that one, this chylothorax, how to manage. Few people maybe knows that one, this is a regular flow chart we regularly see. So I will conclude that one, single ventricle physiology is the parallel circulation. So we are converting into the normal fontan circulation, which is converting into normal series circulation, which is a normally we will see this one. So BT shunt, generally first thing is saturation is, if 80% means you have to, means that pulmonary blood flow is adequate. How is the shunt murmur? And same thing is Glenn shunt is passive circulation is a PBR dependent. So always try to do the permissive hypercapnia in the Glenn shunt. So similar to Glenn, in the fontan also, there is a diastolic function is very important. Try to maintain the transpulmonary gradient more than 5 mm. So thank you. Thank you very much.
So thank you, sir. That was very interesting presentation. So most of the time, the management of these shunt lesions in the postoperative period is really challenging, and one should be aware of complete physiology. Without knowing the physiology, that management is very difficult. So one should be aware of this physiology in the management of the shunt lesions. So with this, we'll end this session. So this series of lectures will finish, and tomorrow we have a workshop, physical workshop. So it will start around 8 o'clock in the morning. So 8 to 8:30 there will be registrations followed by breakfast. And 8:30 to 9:30 we have 2 lectures by 2 of our senior faculty, followed by workshops. We have a very interesting workshops like functional echo and basic cardiac structures. We'll show, we have an anatomy specimens, and anatomist will be explaining the detailed things and all, and session workshop on inotropes as well as shock, and coming to the ECG basics, and we'll have an workstation on ECMO support as well as cardiopulmonary bypass. And we have a different case scenarios of cardiac cases for emergency stabilization. And at the last, we have an importance of chest X-rays presentation by Dr. Sudeep Verma. And so it will be there for around 6 hours from morning, starting from morning 8 a.m. to the afternoon 2 p.m., followed by a conference in Hotel Abode. So any kind of doubts related to the today's topics, you can raise here in the chat box, or if you can, or if you have any other doubts and all, you can clarify in the tomorrow's workshop also. So any other any concerns or anything or any doubts? If there is nothing, we'll end this session. Okay, we'll end the session. So we'll meet in tomorrow's workshop. So thank you everyone for attending today's workshop, and Thank you.